Good morning and welcome to the 29th meeting in 2012 of the Health and Sport Committee. As usual, can I remind anyone present that mobile phones and Blackberries should be switched off, as they can often interfere with the sound system. Our first item on our agenda today is continuing scrutiny of the Scottish Government's draft budget 2013-14. And can I welcome our final panel of witnesses to the committee? Can I welcome Alec Neil, Cabinet Secretary for Health and Wellbeing. Welcome, Minister, to your first meeting of the Health Committee, and we look forward to working with you over the future period. John Matheson, Director of Health and Finance Information, and Derek Feely, Director General, Health and Social Care and Chief Executive, NHS Scotland, all from the Scottish Government. Can I offer the Cabinet Secretary an opportunity to put some remarks on the record?
Thank you very much indeed, Convener. And it seems every time I get a ministerial change of the portfolio that you end up as the convener that I report into. But it's a welcome development. Can I say, since this government was elected, a record of achievement has not only led the way in the UK, for example, improving patient safety and massively reducing waiting times, but is recognised internationally as innovative and aspirational in its scope and potential for improving health and health care. All of this has been undertaken within the context of the most dramatic reduction in public spending ever imposed in Scotland by the UK government. Within these constraints, we continue to deliver on our manifesto commitment to pass on the Barnett consequentials to health. Resource funding will increase by £293 million in 2013-14, and NHS territorial boards will receive allocation increases of 3.3% on 2013-14 and 3.1% in 2014-15, which will be directed towards frontline services. This means that the core budgets of our territorial health boards have been protected in real terms in each year of the spending review period. The core health capital budget will be supplemented by identified revenue to capital transfers of £320 million in the spending review period. Further investment in improving the NHS estate will be available through delivery of revenue finance projects equivalent in capital terms to an additional £750 million of investment. This means there will be over £2 billion of capital investment in the NHS estate over the spending review period. In delivering our NHS healthcare quality strategy ambition of effective care, we have made significant improvements to health and healthcare outcomes for the people of Scotland. We have made a significant contribution to the marked reductions in mortality rates from the three big killers, cancer, heart disease and stroke. And the Scottish Parliament has passed world-leading legislation to reduce minimum pricing for alcohol. The National Keep Well programme of inequalities targeted health checks has successfully engaged more than 180,000 people. And we've rolled out our Detect Cancer Early programme, which aims to increase the early detection of cancer by 25%. We must be bold enough to visualise the NHS that will best meet the needs of the future in a way that is sustainable, and then make the changes necessary to turn that vision into a reality. Key priorities for 2013-14 will be: 1, to develop a shared understanding with everyone involved in delivering healthcare services; 2, secure greater integrated working; 3, prioritise anticipatory care and preventative spend; 4, prioritise support for people to stay at home as long as appropriate; and finally, to take action to ensure that people are admitted to hospital only when it's not appropriate to treat them in the community. That's a brief overview, Convener. Hopefully it gives you a flavour of the direction of travel that we intend to pursue, and delighted to obviously answer any questions from the committee.
Thank you very much. Our first question is from Dr Richard Simpson.
Thank you, Cabinet Secretary, and welcome to the Health Committee. As you've stated there and in the letter which you sent to the convener, you paint a really quite rosy and optimistic picture, which is slightly paradoxical because you opened today by saying the largest public sector cuts that had ever been imposed, both actually on Scotland and on the rest of the United Kingdom. It's interesting that the health service in England is said to be facing cuts over the spending review of £20 billion, which is a massive amount, and the equivalent cuts here would presumably be in the region of £2 billion. And yet you've painted for us again this morning a highly optimistic picture of a health service which is going to be able to, is delivering, and in fact it has delivered, but is going to be able to deliver all your aspirations. Now, that's all very well and good, but we know now from Audit Scotland, for example, that 3 health boards last year were lent funds, and that's in paragraph 24 of the NHS Financial Performance Report from Audit Scotland. And we also know that there are high-risk efficiency savings, that's in paragraph 41, exhibit 8 of that same report. Indeed, in the case of Lothian, 60% of the efficiency savings are regarded as high risks. So can I open up by asking, in your letter to us, you also said that the local development plans were on track at the end of September to deliver both the financial balance laid out in their local development plans and their efficiency savings. So my question is, first of all, the 3 boards that have been lent funds, why was that not reported until we got the report from the Audit Scotland? When will the money be repaid by them? Will it be this financial year or next, or when will it be repaid? Because they're all on track to have 0 at the end of this year, balance, and yet they've got these loans. The second thing is, the second bit to this is that I have quite significant concerns about the budget situation, and if I may illustrate that by saying that, having exposed the waiting list scandal games in Lothian, and we will await with interest the Audit Scotland report on waiting times, but we also now know that in the case of Lothian, they're about to offer 500 patients treatment abroad to meet their targets. So the capacity problem in Lothian, at least, is significant. And if it's significant for Lothian, I just wonder how significant it is elsewhere. We also know the borders now are offering patients treatment in England, not just for procedures that are never available in Scotland, which would be appropriate, but for other procedures which one would normally expect to be treated in Scotland. Indeed, in the last full year for which we have statistics answered in the Westminster Parliament, 8,000 Scots were treated as inpatients in England, and 17,500 were treated as outpatients. Yeah, and this doesn't include accident and emergency. So can I ask him, first of all, to comment on these points? And secondly, will he undertake to ensure that there is put in place increased transparency in financial reporting that Audit Scotland have called for, to ensure this committee can indeed scrutinise the NHS finances in a way that we would wish?
Thank you to answer, Convener. Can I first of all just refer to the beginning of Richard's remarks in terms of the savings of £20 billion in the National Health Service south of the border, which originally was introduced by Andy Burnham, the Labour Health Secretary, and then kept by Andrew Lansley and now Jeremy Hunt, the Tory Health Secretary south of the border. Let me say right away, I am not going to get into a macho competition with the south of the border in terms of who can make the biggest cuts to the National Health Service. Unlike south of the border, we don't intend to tear up the National Health Service. We intend to keep it as an integrated, fully equipped, well-manned and high outcome service, free at the point of use. It's entirely up to the people south of the border if they want to destroy the National Health Service, that the National Health Service in Scotland will adhere and continue to build upon the founding principles that established it in 1948. The second point, let me deal with the Audit Scotland report. First of all, can I make it absolutely clear that all these transfers were in fact reported. They are already in the public domain. They're always in the public domain. I think the point being made by Audit Scotland was the way in which we put them in the public domain should be more obvious. It should be more glaring. And we are happy to look at that and see how we can do that. But it is not true to say that the information was not in the public domain. The information was in the public domain, and I'm going to hand over in a second to John Matheson, who will give you chapter and verse of when and where it was reported. Can I also make the observation that the three health boards referred to by Richard, which were referred to in that report, their auditors are Audit Scotland, and Audit Scotland signed off their accounts. Clearly they would not have signed off the accounts as the auditor if they had thought there had been a major problem. So I think we've got to get this issue in context. The third point I would make about the Audit Scotland report is it is referring to less than 0.1% of the 11.5 billion or so we spend in the National Health Service every year. And if you look at the procedure, which is basically at the tail end of the year, viring resources within the National Health Service, that actually was endorsed by the Audit Committee of this Parliament when it was chaired by Hugh Henry, MSP. He said that was the right thing to do. We are not like the south of the border, where health trusts are profit centres. In Scotland, the health boards are cost centres, but they are part of a national health service. We don't have 14 separate health services, one for each board. We have a national health service. We therefore allocate and, if required, reallocate resources as and when required. Now, in terms of 2 out of the 3 boards that were mentioned, the specific reasons for having to wire funds to them was because of cash flow implications in terms of building projects. The new Vic in Kirkcaldy, for example. Now, every government, not just in the health service, right across all departments, wires resources and is perfectly entitled to wire resources, particularly in the last quarter, to make sure we don't end up with a massive underspend that then has to be sent back by a cheque to the Treasury. So I make absolutely no apologies for that clever and intelligent management and use of our resources, nor do I accept in any way that we have not reported these matters as we have done for years in the public domain, and I further emphasise we have done it in the way endorsed by and recommended by the Audit Committee of this Parliament. So we've adhered to every one of those rules. So I think in terms of the Audit Committee, we'll accept the recommendations to make it even more transparent. We're happy to do that. But there's a difference between making it more transparent, more obvious, and not reporting it. We have actually reported it, and as the auditors of these 3 boards, Audit Scotland knows that. The final point in terms of treating people out with Scotland, that's always very much a last resort and will only be done if absolutely clinically essential. Very clearly, our job is to ensure the capacity exists in Scotland. Now, there have been procedures, such as the TAVI procedure in relation to heart conditions, where until this year, anybody requiring the TAVI procedure had to have it done Firth of Scotland. This government has introduced TAVI procedures in Edinburgh, and you can now get your TAVI procedure done in Scotland without having to travel down south. And that remains our strategy, only to treat people out with Scotland if it's absolutely a last resort. And you shouldn't always believe every word you read in the newspapers, even ones as reputable as the Evening News and the Scotsman. I'm now going to ask John to quote chapter and verse of when we reported...
I think that we are dealing with something that has been raised by a number, and before Mr Matheson comes in, I think you should address some remarks not only to Audit Scotland, but for the evidence that we've had from RCN, BMA, Unison, Sir David Bell, previous committees about the issue of transparency of health budgets over a period of time. I think there's a whole raft of evidence that we've had raising this issue, and including, I think, even from our budget advisor about this issue. So it is important, and I hear the robust defence from the Cabinet Secretary, but I think it is important to address the issues in the broadest terms.
I'll ask John to quote chapter and verse of when we have reported these environments.
I think a couple of just introductory comments that when boards approach us, and we have regular contact with boards around the financial issues that they're facing, we get into detailed discussion with them. We don't automatically give them support. We look to ensure that any issue they have is transitional, and is going to be managed in a recurring basis going forward, so that we have confidence that they have financial sustainability going forward. Of the three boards that have been highlighted by Audit Scotland, two of them, it was around, as Cabinet Secretary said, the move into new premises and the double running costs associated with that. So we got that reassurance, and I'll just focus on Forth Valley as an example. So we got that reassurance from Forth Valley that they had a sustainable financial plan going forward. They reported on as part of their reporting for the 4 months to the end of July 2011 in their finance report. They talked about a potential overspend of £3 million at that point, with a worst-case scenario in the region of £10 to £12 million. And they then entered into detailed discussions with the Chief Executive and with myself about how that could be resolved. We had those detailed discussions and we offered them support. And that support primarily was funded from capital receipts that were generated within Forth Valley from hospital sales. So it was money within Forth Valley that was going to come in later years that they were going to repay that support. And they then reported for their finance report to the end of 9 months to the end of December 2011. They highlighted in that report to the board that they had received transitional costs, non-recurrent funding of £4 million and non-recurrent support of up to £6 million. Because we were still trying to keep the pressure on Forth Valley to try and minimise any financial issues that they had. And that's why we capped the level of support that we're willing to offer Forth Valley. In terms of repayment, there is a repayment profile for Forth Valley that takes them up to 2015-16. They are on target in terms of their financial position, in terms of the current financial year, as indeed are Fife and Orkney. We will, of course, look at transparency and see how we can be more transparent. I, for example, meet with a lead official within the RCN on a quarterly basis to discuss financial matters. We share the monitoring returns from each individual board with the RCN at their request in terms of trying to be as transparent as possible in terms of the information that we provide. So what we're trying to do here is we're trying to, and the context is important, it's 0.1% of the total health budget. So we're trying to enable boards to plan for the future in a sustainable way, but also manage the reality of current pressures in a controlled and effective way. And that's what we've done with those three boards. This is not new. Sorry, a final point if I may, Convener. This is not new. I can go back to NHS Lothian in just after the turn of the millennium, who received support from the Scottish Government, recognising double running costs in their move down to the new Royal Infirmary. And even in the current financial year, Dumfries and Galloway have actually returned £4 million to Scottish Government and asked for that to be banked, in inverted commas, carried forward for 2 or 3 years, which we will do on their behalf, and they will then receive that back to cover the double running costs around their move to the new Dumfries and Galloway Royal Infirmary.
Derek's going to supplement that a bit.
So we're very keen to be transparent, and if there are issues that the committee wants to bring to our attention, and we'll respond to them favourably. But just to supplement what John said, one of the things we do already is John gives a finance report to the Scottish Partnership Forum. So the Scottish Partnership Forum is a meeting of government, management side in the NHS and the trade unions in the NHS, including the BMA and the RCN, who are represented at that. So they hear that financial report on a regular basis from John. It's a kind of unique feature of the NHS where we openly share that kind of information with our partnership colleagues. But if there's more we can do, we'll do it.
We're going to bring Richard Simpson back in, but also remember Argyll and Clyde. Yep. Selling the family future, it's not a sustainable position, from my personal experience.
And there's also Tayside, which got into real financial difficulties as well. I mean, our concern is to see future as to whether there are problems, and thank you for the explanations you've given. At least we know these loans are related to capital issues that are requiring double running, so we can be clear about that. But Cabinet Secretary, if I can come back to your robust defence and your suggestion that we are different in Scotland, we are facing a different situation. I accept that both your party and mine have actually moved the health service in Scotland down totally different lines to that in England. That is the choice of the Scottish Labour Party, as it has been the choice of the SNP. But the facts are, Cabinet Secretary, that despite your saying that, you know, we are not going to have cuts in Scotland, we have lost 2,500 nurses. And in Forth Valley, which has just been talked about just now in terms of their financial situation, that is 50 nurses in the last year. 50 nurses serving a population of only 180,000 people. That's a very substantial cut. And as I have indicated in the Chamber repeatedly, we cannot have a situation in which it is not recognised that the loss of 2,500 nurses does not have frontline consequences. And if that unreality continues, then we are going to be in really significant trouble within a year or two. So one of the streams you mentioned in your letter, Convener, in the letter was workforce planning. Will you provide us with the most up-to-date workforce plans for what posts are going to be lost this year? Because I have been unable to obtain this through an FOI inquiry. I've had replies from Grampian saying that because I used the word axed in the FOI, and I don't care what the thesaurus says, these posts have been axed, that Grampian deny any posts have been axed. And that sort of response from the Health Board is not the sort of transparency on which this committee can operate, or indeed any MSP can operate. So will you give us the workforce planning, and will you acknowledge that 2,500 posts have been cut, and that this is putting the system under massive pressure?
I'll deal happily with all of those points, Convener. Can I just, though, give an example of the kind of financial pressures we're under? If you look at NHS Lanarkshire, for example, it has to fork out £45 million a year to pay for the PFI costs of Hare Myers and Wishaw. Now, in Lanarkshire, for example, that's a huge dent in the Lanarkshire budget because of the rip-off of PFI. And we are now having to pick up the tab for PFI with all the consequences that goes with it. So I don't think that people who supported PFI are in a very strong position to criticise the budgetary position of the National Health Service. Now, specifically on nurses, let me make 3 points. First of all, in total, there are more qualified nurses working in Scotland today than were working in the health service 5 years ago when we took over. Secondly, when you look at the number of nurses per patient, the number of nurses per bed, we are far, far better staffed in terms of nurses than any other part of the United Kingdom. So we have a very good staffing position in relation to nurses generally in comparison to the rest of the United Kingdom. Thirdly, we do, however, need to recognise that the National Health Service is being reconfigured. Dr Simpson himself, on the 8th of June last year, said to the committee that he accepted the shift of balance of care that could result in a reduction in the number of acute beds. By definition, we are moving more to day surgery. We are moving more from hospitalisation to treatment in the home. And that's why, for example, there's been a 30% increase in recent years over the number of community nurses we have in Scotland. However, I do recognise that it's very important for us to be absolutely sure that we have the number of nurses with the right skills mix right throughout the health service in Scotland, irrespective of what department they work in, irrespective of what hospital they work in, irrespective of whether they're working in the community or the acute sector. And that is why, with our partners in the trade unions, in Unison, the RCN and others, we have developed the worldwide leading workforce planning tool in Scotland, which has already been 90% implemented, will be 100% implemented in the first quarter of next year. We are going to make that tool mandatory for every board in Scotland from next April. So every board will have to apply that tool, which has been agreed with the trade unions and the RCN, been agreed as the way properly to plan our workforce to make sure we have the right numbers, we have the right skill mix, we have them in the right place at the right time. We can reduce substantially further our reliance on bank nurses. We've eliminated reliance on agency nursing, and I believe that's the way forward. Now, I think if you only conduct a debate on raw numbers, that's a very juvenile way to approach planning your workforce. In the raw numbers, actually, we have actually increased in the last 5 years. But the key thing is to make sure, not just that we've got the right number of nurses, but that they're in the right setting, either in acute or in community or in A&E, that they have the right skills mix, that we de-layer the management structure so to make sure maximum resources go into frontline nursing. That's exactly what we're doing. And as I say, we're going to make the tool mandatory from April next year. And I think that is the way forward rather than just bandying about numbers.
Well, again, I think we're relating to the evidence that we've had.
Absolutely.
You know, so I think that should be borne in mind. The Audit Scotland did, you know, highlight the significant cut in the nurses' numbers in that area, and I concede, you know, and it is an indicator that we are moving. But we had 58,428 nurses in 2009. By 2013, that will drop to 56,101. There's a couple of thousand nurses there. I also recognise at the other column that we're going to see people involved in personal and social care increase by 1,000 over that figure. In addition to that, though, the other representation we had, and it's not about the situation and the squeeze that's on, what it doesn't tell us is that some of the evidence that we had from Unison in regards to the non-filling of vacancies, which is on top of this, and the increased pressures that are coming on those within the hospital setting, professionals in there. You know, there is an issue there, and I take it that is that being dealt with. It's the day-to-day pressures. I mean, you know, I think you've highlighted the level of planning. I think we can see that fewer nurses and more people in personal social care, you know, happening here. But there is this question of what's happening on a day-to-day basis. Non-replacement, vacancies not being filled. At the same time, cutting bank nurses, overtime and everything else to keep those costs down.
I think the
puts the pressure on. And nobody, and as you say in the raw numbers, is measuring the quality.
Yeah.
The patient experience and indeed the reputational risk that carries. And, you know, we've seen some horror stories about personal care in the recent reports, for elderly care in recent reports, and the older people in the acute hospital setting. So what's giving here, I think, is the question.
Can I make 2 or 3 points in response to the very reasonable points you make, Convener? First of all, in terms of vacancies, at the moment there are 900 vacancies for nursing positions in Scotland, and given the controversy over numbers, I've been taking a very, very close look at the profile of the vacancies as well as the profile of the numbers. And in particular, I've been checking to make sure that boards have not been prolonging the length of time the vacancies have gone unfilled for budgetary reasons. I'm absolutely satisfied myself that 900 number is a fairly reasonable number given the totality of the levels of employment of nurses in the National Health Service. You know, if you take your figure of 56,000 and take 900...
Scotland's figure.
Or Scotland's figure of 56,000 employees. Remember, of course, the distinction between the number of employees and the full-time equivalent. And I think we need to also bear those figures and the distinction in mind. So 900 is not an unreasonable level of vacancies to have at any one time. But I have sought assurances that, and I'm, you know, myself keeping this under constant monitoring to make sure that we are no board is using vacancies as a way of saving money. If there are nursing vacancies, those vacancies should be filled at the earliest opportunity, and that goes without saying. If, by definition, the vacancy is advertised, it means we need that nurse, we need that vacancy filled, and it shouldn't. The time to fill the vacancy shouldn't in any way be delayed, and that's what's happening. The vacancies are being filled in the normal kind of turnaround time.
Can you share that information with the committee? I mean,
absolutely, no problem. And you know, if you want more information, as I said to you in our bilateral meeting last week, if the committee at any time feels as though it doesn't have any information, financial or otherwise, that you should have, let me know and we will provide it. We have absolutely nothing to hide whatsoever. And as Derek said, we believe in total, full transparency. The other point that you made is there are sometimes pressure points. And there is no doubt there are sometimes pressure points. For example, the overall level of sickness absenteeism in the National Health Service is higher than we would like. Sometimes that absenteeism can create pressure points. That has to be managed, it has to be dealt with. But the whole point of the workforce management and planning tool is to deal with those pressure points as well. Now, the tool is 90% applied already across the National Health Service in Scotland. That will be 100% by the spring of next year. And from then on, the tool itself will be mandatory. And I think that should ensure, Convener, that those pressure points are identified very early on and are therefore dealt with more speedily than even in the past.
You did say that everybody was happy at the evaluation of that tool with the...
Yeah, we've involved Unison and RCN and,
So
and
again,
others.
because I think it is important when people come along and give us evidence that we test that evidence today with you.
Yeah,
with
and to be fair, I think, Convener, I think it is true to say, and I'm going to hand over to Derek to give you some supplementary information, but certainly my understanding is, and certainly from talking to other people in international medical visitors to Scotland, this tool that we have developed is seen as the leading workforce planning and management tool in Europe as far as health service provision is concerned. Derek?
So just to confirm, we have developed it in partnership. My understanding is, RCN can speak for themselves, but my understanding is that RCN have been advocating the use of this tool beyond Scotland. Would like to see it used in England, for example, where it's not in current use. It is about trying to identify those pressure points that the Cabinet Secretary referred to and that you, Convener, were keen that we understood. So it's about helping to try and identify these and translate that through into what are the staffing numbers that you require. It's not going to be a panacea, and we're not pretending it is, but we've got other things in place. We've introduced the one-year guarantee scheme, for example. We've got internship in nursing to make sure that people get good experience while they're waiting for permanent posts. Again, it's easy to we've become accustomed to that. But again, those are unique to Scotland, those kind of opportunities for nurses. And just to pick up on something that Mr Simpson said in his opening remarks, because I think it's important to firstly to acknowledge his comments about these matters, that the quality of healthcare in Scotland is good. You know, it's safer, that infections are down, hospital standardised mortality is down, waiting times are low, care experience is high and being sustained. So, you know, no one's pretending there are no pressures, but the NHS is performing well currently, and we expect it to continue to perform well.
At this point, you should address that other one. Then the first was it the first evidence session with John McLaren was challenging us all. I think politicians and government. Top target: healthy male life expectancy down 1.5 years in Scotland, up.
Yeah,
3 years or 2 years. 3 years in England, 4 years in Wales, and the top target hasn't been met. Nobody's done anything about it. And, that was one of the biggest focuses on outcomes that's not been met.
So I've seen John's presentation of that, and it scared me a bit too when I first saw it. And so I immediately went and asked my resident expert on these matters, the Chief Medical Officer, whether that was indeed the case. And Harry has explained to me, and we will get this explanation to the committee, that this is an artefact of the way in which the data is collected. So
he did say, I think, John McLaren, he did say that, I think, to the evidence committee, he left a caveat there in terms of the thing. So we look forward to
we'll provide the committee with an explanation.
Drew Smith?
Firstly, on that point, Convener, I think John McLaren did make that point about the accuracy of the information we had, but it does kind of lead you to why don't we then have better information if that is genuinely our top target. But I don't know if that's going too off course, Convener, or if you'd allowed the witnesses to.
It also do be a factor of how other people collect their information, and it might not be as robust as ours. So we will provide you with the detail of that, sure. Because it is a fairly technical and not fairly complex, but we will provide you with the detail.
I think that's useful, okay, Cabinet Secretary.
Mark?
I was simply indicating that I wanted to speak later on, Convener. If you have a list, then I'm happy
No,
to
that's
be,
okay then.
take,
Bob
take
Doris,
take my
thanks,
place.
Mark. Yeah. Gil Patterson.
Thanks, Convener. Cabinet Secretary, at last week's evidence session, I asked the witnesses, in terms of the real terms increase in the revenue budget to health boards, if they wanted to reallocate some of that money, how would they reallocate it? What would their priorities be? And if I recall, we only got 2 takers. We got Unison saying that they would have greater efficiencies in accident and emergency units, and they mentioned Ayr and Monklands, which I didn't ask them to clarify that just in case they were going to suggest that we close those, because clearly that's not a priority for the Scottish Government. And the voluntary sector said that more money in change funds should be allocated towards them, funnily enough. So can I ask you, Cabinet Secretary, given the fact we can see what financial support has been delivered by the Scottish Government to health boards, what representations you've had as Cabinet Secretary to reprofile your spending priorities, because we couldn't really get any takers at committee, and when we looked to do our draft budget, we have to take these things quite seriously.
To be honest, apart from general comments from people about delayering the management or issues of that nature without being specific, we haven't had any. I've only been in this job, remember, 5 or 6 weeks, but I haven't had any detailed proposals from anyone on reprofiling the budget either for this year or any of the next 2 years. But it might be useful if I just explain where we are in terms of the budget, because obviously we made a manifesto commitment that we would pass on all the Barnett consequentials to the National Health Service, and we have done that. But we've specifically done 2 things for the next 2 years. One is that we have made sure that there's a real-term increase in the budget allocated to the territorial boards, because they are the ones primarily, not exclusively, but they are the ones primarily involved in frontline services. So that next year, with a deflator of 2.5%, the boards are getting an average of 3.3%. That's a 0.8% increase in real terms in their budget. And then the year after that, with the deflator still at 2.5%, they're getting 3.1%, so that's a 0.6% increase. So the first thing we've done is make sure that there's a real terms increase into the frontline organisations in the health service in Scotland. The second thing is to shift some money from resource into capital. Very clearly, there are major capital works that we need to ensure happen. So as well as shifting some resource, 300 million, just over 300 million over the next 3 years, from resource into the capital budget, we also, of course, have the £750 million NPD programme, and that will see, as you know, I've already announced the go-ahead for the Royal Sick Children's new hospital in Edinburgh, a long overdue project that's been wished for many a long year. And there's a new neurosurgical unit, neuroscience unit in Edinburgh as well, and a whole range of other things as well. So despite the massive cuts imposed from London, we, I think, have made very good use of our resources over the 4-year period. Our efficiency savings, which will not in any way undermine our clinical objectives, they will accumulate to nearly £1 billion, and every penny of that £1 billion is going back into frontline services.
Specific, I do note that I didn't actually say how any particular group would ask you to reprofile the health budget. But to the specific, I met yesterday with psychological services at Glasgow and Clyde Health Board, because they've got an interest in pushing forward the targets for children's access to psychological services. Now, only a year or two that wait was 1 or 2 years, in fact, to get a clinician-led psychological support. It's currently at 29 weeks, still not good enough, they would say as well, but dramatic progress in the correct direction. I did see they had prioritised financially a budget line for that particular area. So it's an example of where when the health board sets its budget in correlation with the heat targets, you start to get the results that are required. So my question would be, there's a whole series of priorities that the Scottish Government set out. How do you monitor to make sure that health boards are then financially prioritising what are Scottish Government targets? Because it's not just about the money you give to health boards, it's how they then prioritise those agreed targets.
Yes. There is a great deal of monitoring that goes on. For example, I meet, and my predecessor met, the chairs of the health boards on a regular basis, all 22 board chairs on a regular basis. Derek meets the chief executives once a month. There's also a lot of bilateral meetings. For example, John meets his finance counterparts on the boards on a regular basis. John Conahan, who's in charge of workforce development, clearly meets his counterparts in HR on a regular basis. And we have monthly reporting on a whole range of indices of performance. And I am going to be pulling that together at ministerial level into my own internal monthly management information report. And my main, it will have a number of sections, but the most important one to me is actually the treatment outcomes. That is absolutely the core of how I think you decide on the success or otherwise of a health system. So I want to look on a regular basis. Obviously, you won't look at every treatment outcome every month, but I want to look at very closely treatment outcomes, the cost of treatment outcomes, and to benchmark the treatment outcomes against the best to see how we are doing. And that would be in relation to the cancers, heart disease, stroke, and all the rest of it. Now, a lot of that's already done, and to some extent this is a collation exercise, but I can assure you, whether it's on cancer, heart, waiting lists, a whole range of things, heat targets, heat standards, we get very, very regular reports. You just need to look at my box of an evening or a weekend to see how many reports we get from all round the health service in Scotland in terms of meeting their performance targets and their outcome targets.
One final question on that, Convener. In relation to the heat targets and the variety of priorities the Scottish Government has, the financial budget that's set by local authorities to achieve those, and of course the outcomes, because the budget of course is the input, and I have to say it wasn't a dramatic increase in financial resources that Greater Glasgow and Clyde input in order to get quite a dramatic improvements. It's not always the amount of money that's put in. If you organise your services correctly, you can get a quality output. Do you, across the 14 health boards, do you monitor the input, the money put in to specific budget lines and compare the outputs? Because it's important, if one local authority is performing well in an area and another's not, that best practice is shared to make sure we're not just monitoring the money we put in to the health boards, but we actually get the outcomes desired. Is that something that's done on a standard basis?
Absolutely. I mean, the whole emphasis has been changing in terms of targets. As you know, the heat targets have been consolidated into 16 targets, and we're carrying out further review to see if they need to be updated, need to be changed in any way to reflect what's a dynamic situation in the health service. But you know, that compares to many more targets before. You could end up with too many targets and then you end up not achieving any. But the fact of life is that we look at the outcomes, and we are much more outcome orientated than ever before. And it's the outcomes that matter. And as I say, what I'm keen to look at as the Minister in charge of the health service in Scotland is looking at a load of things, the finance, staffing and all the rest of it. I even look at what the opposition parties are saying to see if I see a good idea. I have to say, I haven't seen a lot recently. But I look at all the outcomes, and I look at the cost of the outcomes, and I look at benchmarking the outcomes as well, so that we've got a very clear picture of how well we're doing historically, how well we're doing and planning to do in the future, and how well that compares with the best. John, I think, wants to add a bit more in about the relationship between the outputs and the inputs.
Just a couple of points, Convener. In terms of financial planning, what you don't want are surprises. So in terms of the draft budget for 13-14, what the boards, they welcomed the outcome, but they also welcomed the fact that it was what they were expecting in terms of uplift. So they've been planning on that basis in terms of their financial plans going forward. So the spending review has been very helpful in giving some assuredness going forward over the period of the spending review in terms of what the boards might expect. The other thing the boards want is they want as much as possible into their baseline. So we've been putting more and more resource into the baseline of boards. So for example, access monies, we put an additional tranche of access monies directly into the baseline of boards. Cabinet Secretary is right, we've also been trying to focus on outcomes and outputs and get the boards to focus on that. And we've tried to move away from a sort of micromanagement approach where we give boards smallish allocations for specific targets. And we've tried to bundle them, and we have succeeded in bundling them around about themes. So there's a theme around about primary care, a theme around about the early years, around about the mental health, etc. And that gives the boards local flexibility, which is important to as to how they use that resource, providing they deliver on the required outcomes and the outputs.
Yeah.
So
feeling.
we very explicitly connect finance and performance. So the local delivery plan that every board needs to construct has both its commitments to meet its heat targets and its financial profiling. When, as we did in Fife yesterday, the Cabinet Secretary conducts annual reviews with boards. We talk about both performance and finance. We don't talk about the two separately, we talk about them both together. Likewise, in the mid-year reviews that officials do with boards, we talk very much about both performance and finance. And just two other things that might give Mr Doris a little bit more comfort. We have done very specific benchmarking of boards in terms of what they spend against their outcomes in a number of areas, and mental health is one of them. We've done it on theatre utilisation as well, for example, just to make sure that you get value for the spend. And we've started to, we've started to develop some tools to help boards make those kind of assessments, like the Integrated Resource Framework, which is a tool intended to help them look at what they get for the investment that they make. So there's quite a lot of effort going into that.
I think Mr Matheson's, I think you've hit on it in no surprises in planning, and I think the evidence that we've had is all about that. Are we planning properly for a shrinking budget? I think I think we're already there as a committee, but there are a number of potential surprises. There is a £1 billion maintenance backlog. Now, I understand some of that work could be a lick of paint somewhere, but in other places where and some boards are using revenue funding to spend, in your own constituency, the Cabinet Secretary, are using revenue funding because they've not got the capital spend. We've got a recent, I came across it just last night in Audit Scotland, where they were planning for a good decision, a legal decision on equal pay. I think that might have went upside down. And that's no surprise, because local authorities have done that for many, many years. It's cost us an absolute fortune. But equal pay's in there. And, there's, many thousands of people in line there. And we look at efficiency savings. And again, guided by Audit Scotland, they're saying people haven't identified where that money's going to come from. And there's a risk that they might not get those savings. So we are looking at the robustness of what's happening in the health service, because as we heard last week from RCN and BMA, the worst thing we can do here is not plan for these eventualities, to see services collapse. And that's, I think, where we are. But there are many surprises lying in there still. There could be.
I wouldn't describe them as surprises. I mean, we do scenario planning, obviously, convener, and if you take the backlog, for example, which was the subject of a very full review earlier this year under my predecessor, and there's very clearly now fairly advanced estate strategy operating in the National Health Service. Now, it would be a lot easier to implement if all the surplus properties were bought up in the market. Because of the condition of the economy, properties that might have sold quite quickly a few years ago clearly are not moving as fast. But we are very clear, and we do know, where the risks are. We look at contingencies where they're required. So, inevitably in life, sometimes you do get the odd surprise. But
it's a big number, Cabinet Secretary.
Absolutely, and we are I think we're very much on top of where the risks might be.
How much is that? I mean, we'll take the big top line figure that covers everything from a lick of paint in the reception area to, the cladding on Inverclyde Royal Hospital. What figure is the big risk?
Well, I'm happy to send you. There's quite a detailed analysis of that backlog. For example, that £1 billion figure included buildings that are actually declared surplus to requirements. Right. For example,
yeah,
so clearly they're not going to be getting a high priority in terms of backlog spend. And when you boil it down, the figure is substantially less than £1 billion in terms of where we really need to spend the money over the next few years.
What is it, Mr.
John's going to give you the detail.
I think this is a very good example, convener, of transparency, because I know we quite went down to the lick of paint, but we did look at low risk, high risk, significant risk, as well as medium risk, and the final figure was just over £1 billion. When you break that down, I'll give you one board as an example in a moment, but when you break that down into significant risk and high risk as opposed to medium and low, then the figure roughly halves. When you take account of what is in the planning programme in terms of Dumfries and Galloway Royal Infirmary, Cabinet Secretary mentioned St Children's, there's Ayrshire and Arden Community Hospital, there's Balfour up in Orkney, then that brings the total figure down to about just over 400,000 in terms of the residual figure. 400 million. 400 million. Thank you for the correction.
I wish it was 400,000.
400 million. I'm normally quite good with numbers. 400, just over 400 million. Dumfries and Galloway is a good example. The gross figure as part of that £1 billion in Dumfries and Galloway was £61 million backlog maintenance. 40 million of that will be dealt with through the Dumfries and Galloway new hospital, Dumfries and Galloway Royal Infirmary. 5 million of that will be dealt with through disposal of the properties. And there's a backlog maintenance programme to deal with the balance. So immediately you come down from £61 million down to just over £10 million for Dumfries and Galloway.
So we don't face a situation, as been suggested, that it's not just the fabric of buildings, but actual diagnostic equipment, high-tech equipment that's not included in this, as Audit Scotland suggested?
The equipment is not included in that figure. We have a separate programme for equipment replacement, and that's one of the reasons why we've transferred £320 million across from resource to capital over the 3 years.
Where is that figure then for the replacement for?
I don't have that detail in front of me. I can give the committee that detail.
Yeah, we'd welcome that as well.
We're happy to send you the detail of this, convener. Can I also point out, of course, that also some of the spend actually saves money. I'll give you a very good example. You may be aware of it. The electronic pen that was developed by the community nurses in Western Isles. The community nurses in the Western Isles did an exercise which showed that 41% of their time was spent on administration. And they developed an electronic pen, which basically means when they're out in a remote cottage or whatever, attending to a patient, and they write up the notes, it automatically updates the computer. They don't need to go back to the office, then type it all back into the computer, and so on and so forth. And it's got many other applications as well. But that single application, the community nurses in the Western Isles reckon, reduced their time in administration from 41% of their time to 20% of their time. So that fairly modest spend, because obviously as more people do it and the unit cost comes down, could save a lot of time, get a lot more throughput for community nurses and make their job much more enjoyable, because they're only spending 20% of their time in administration instead of 41% of their time. So that's a very good example of where the application of technology has knock-on savings and efficiencies as well.
I look forward to getting onto that preventative agenda later on. But the equal pay, have we established a liability there for the boards?
In terms of the equal pay, we work very closely with the Central Legal Office in respect of this. The current advice that we have, there's a differentiation in the position within local authorities and the position within the health service. And for the last number of years, we've recognised it as a potential risk. We are not in a position to put a value onto that risk, but we're working closely with the staff side in taking that forward. So at the moment, it's what we describe as an unquantified contingent liability in the accounts. So we recognise it as potential risk, but there's not a possibility to put a value on that at the moment.
Has the risk increased since the Birmingham situation? Because I noticed in Audit Scotland that there was an expectation that the time bar could be favourable for the health service. It actually mentions that, so I don't know.
I'm
aware it's something you can come back to.
I'm aware of that, and we stay close to Central Legal Office. And the other, just to go back
it doesn't fill me with confidence, Mr. Masterton, because we've got in local authorities the legal advice has not been absolutely great over the years, and it's ended up costing us more. But anyway,
I think a final point on that, if I may, convener, we do stay close not just to Central Legal Office, but also to Audit Scotland. And every year we sit down with Central Legal Office and Audit Scotland and we come to an agreed position for the annual accounts in terms of transparency around how we're going to report equal pay, and we will continue to do that going forward.
Yep. Be happy if you could keep the committee up to date about
absolutely.
progress. Mark MacDonald.
Thank you, Convener, and thank you for your evidence so far, Cabinet Secretary. But quite neatly follows on from some of what Bob Doris was talking about, because obviously at the last evidence session, well, the first of the evidence sessions we had last week, as Bob Doris identifies, the question was asked, how would you reprofile spend? We then sort of moved on to, are there things you would stop funding? And I would add to what Bob Doris has been saying there that the BMA flew the kite of homeopathy, but we won't go into that debate here. But just to say they were somebody else who had highlighted a service that perhaps needed to be looked at. But I don't want to have a debate about homeopathy today. But the question I would ask is that obviously the issue around what we spend money on in the National Health Service or in general has become somewhat more in vogue recently with recent interventions around, you know, do we stop providing things? Do we reintroduce certain charges or certain elements of means testing? And I wondered what work the Scottish Government is doing around the data that lies behind the, you know, not just the cost of providing a particular service, but also what the cost saving of that service is. I mean, I had a recent briefing, for example, from Optometry Scotland, who spoke about direct and indirect savings as a result of the universal free eye tests. And I was quite shocked at how much they had identified. I've asked them to send me a copy of the report, because it's a report that's been done by a number of universities around both the direct and the indirect savings. So I guess the question would be is, you know, what work is being done to ensure that, you know, we don't just look at the input measure and how much money we're putting in, but we also look at the outcome, not just in terms of health and well-being, but also in terms of what would the cost be if we were not spending that money, what would be the knock-on effect.
Say it's not just about spending money. Some of the measures we're taking should, when implemented fully, save the health service money. I mean, minimum unit pricing is a very good example. Once we get minimum unit pricing introduced, the impact not just in the health budget but in the criminal justice budget, for example, will be quite dramatic. So as well as where we spend money, it's also about what measures we can take that don't necessarily involve a great deal of spend by the government as such. But in terms of spend, let me take an example of free personal care or free prescriptions. Before prescriptions were made free to everybody, 88% of people in Scotland qualified for free prescriptions. If you look at the other 12% who did not qualify, 600,000 of those people were people earning £16,000 or less. Now, some people may say £16,000 is a lot of money, but when you consider that you start paying income tax after you earn £8,100, you start paying national insurance contributions, I think, at 11% after that figure as well. You start paying council tax when you're earning under £7,000. So by the time those three taxes alone come off the top line, you know, you've got a lot less than £16,000. So if you then have to go to the doctor because of an ailment, and then you're asked to fork out £7.45, which is the cost of a prescription for each item south of the border, then you quite frankly would think twice about doing it. And the result may well be that by not buying the prescription, by not taking the medicine, you actually end up in a position where you make a greater call in the health service in the future, because you haven't dealt with at the earliest possible opportunity the ailment for which you got the medication. And the evidence shows, in fact, actually, if you look back to 1948, and looked at the productivity gains arising from free prescriptions and free eye tests and so on when the health service was introduced, it was phenomenal, the impact in those days. Now, I'm not suggesting it has the same percentage impact now. And if you look at free prescriptions, if you take that 88% and then take off the 600,000 who should have been getting free prescriptions, quite frankly, then the numbers left are relatively small, and the cost of collecting prescription charges from these people, it wasn't worth the candle, which is a very good example of where you're better to follow the old maximum from each according to their ability to pay, to each according to their need. And prescriptions are a need, which I believe should be free at the point of use. And I think the health benefits of doing that, and it's something that we monitor, we look at the pluses and the minuses. Similarly with free personal care, you know, if people didn't have free personal care, what would be the cost in terms of additional falls, additional admissions to hospital, additional admissions to accident and emergency, for example, because people didn't have that kind of contact. I think there's been some work done in this. We need to do more work in all of this, obviously, but I certainly think free prescriptions, as an example, there is no doubt in my mind at all that it's the right thing to do, and the cost-benefit of that is a plus.
To move on to another point that's been raised already today around the transparency agenda, and I welcome your remarks thus far. The committee has identified that there's around 341 million is transferred from health budgets to local authority budgets. And I guess the question the committee has is around how closely is that money scrutinised once it has then gone to local authorities. I mean, I realise within an £11 billion health budget, it's small beer, but yes, it's still quite a substantial sum in and of itself. And following on from that, to maybe link that to the Change Fund, because we didn't have oral evidence from Age Scotland, but they did supply written evidence where they had indicated that they had some concerns around how certain local authorities were administering the Change Fund, and it perhaps wasn't being spent along the lines that it was intended to be spent. So I guess the question would be, how closely are you monitoring the use of NHS resources once they are transferred to local authorities, either directly or through the Change Fund? Well,
actually, we're monitoring them very closely, and I'll ask John to give you the kind of detail of the processes that are in place to monitor it. But the Change Fund, of course, is early days yet, and we will be carrying out, after the first year, an evaluation of the Change Fund and how it has worked. There are very clear guidelines on what Change Fund money can be spent on. And as you know, for example, 20% has to be spent on carers support, just one example. So we will be looking at that at the right time, once it's been up and running for at least a year, fully up and running, and we'll do a proper evaluation of that, and we'll share that, obviously, with the committee convener. But we are obviously, where we do get people telling us that the Change Fund isn't being used for things, then we obviously talk to the people concerned to try to find out what's going on. But at the end of the day, we'll do a full-scale evaluation of the Change Fund once it's been up and running for a reasonable period of time. And making sure that people follow the guidelines. I mean, it's very clear what the money can be spent on. And in fact, we prescribe, such as in carers, what money must be spent on within those guidelines. In terms of the flow of money from the health service to local authorities, obviously we keep a close eye on that as well, and I'll get John to spell out the kind of detail of how that's audited. At the end of the day, of course, it's all audited by the Audit Office, the Auditor General, because it's a flow of money within the public sector. I mean, a very good example is NHS Lanarkshire recently gave £1 million towards the cost of a refurbished car park in the centre of Airdrie, because it had to accommodate the additional footfall from the new health clinic that was being built in Airdrie. Now, that's an example of where we, NHS Lanarkshire, can clearly see and make sure that that £1 million was spent in the car park, because the car park's physically there. And very clearly, that's a very good example of where it's very obvious that the money has been spent for the intended purpose. But I'll ask John just briefly to outline the kind of detailed audit process we use in terms of making sure the money is spent where we said it would be spent.
Just a couple of points on this. In terms of the £341 million, which relates to resource transfer, the accountable officer is still the chief executive of the individual board, so they have a responsibility to do that. But I think it goes back to a previous discussion that we had about not just focusing on the money, but also focusing on what the money is intended to deliver. So the discussion around the effective use of the monies would also focus very clearly on delayed discharge position, within that individual board area where the delayed discharge position is going. And over the next 2 or 3 years, there'll be more aggressive targets being brought in terms of the delayed discharge position. It's done. The important thing is that as well, it's done in partnership between local authority and the health board, and indeed when you focus on the change fund involving the third sector as well. So the plans are brought forward in partnership, but the accountability relationship for the core resource transfer money sits very clearly with the health board, and that is picked up through the audit process. But the point I would come back to is it's important that we don't just focus on the money, but what the outcomes and outputs we're expecting that money to deliver, and ensuring that they are delivered.
And can I say, looking forward with the establishment of the 32 partnership boards in terms of the integration of adult health and social care, it's very important, I think, to have an integrated budget, which would be money flowing from the health board and from the local authority into those partnerships. And that obviously will require specific audit arrangements, audit and monitoring arrangements to make sure that money is spent properly as well.
Yeah, and just one final question, if I've got time, Convener. Obviously, there's the issue around the public sector pension changes, and I understand the vote was taken in Westminster last night around this. I'm aware that there has been the letter from the Chief Secretary of the Treasury, which has said if we attempt to do something different in Scotland, the money will be clawed back. I don't know if you have any data today on what the implications would be for the health budget if, for example, we follow the calls that some are making to resist passing on the changes to health service professionals in terms of the clawback. But is that data that perhaps could be provided in showing what the impact of the health budget would be?
Well, it always depends on how many people actually stay in the pension fund or join the pension fund. If we picked up the tab for all the additional contributions and everybody stayed in the pension fund, it could go as high as £80 million a year for the health service in Scotland. A more realistic figure may be slightly less than that, but the potential exposure is up to £80 million a year. We think the pension reforms, not just the reforms themselves, but the way in which they're being imposed is absolute madness of the first order. You know, right across the public sector, it's important to have high morale amongst your workforce. And issues like pensions and the productivity, pay, efficiencies should be matters for negotiation, not imposition, unless in the most extreme circumstances where you can't get a negotiated settlement. So we think the proposals themselves are extremely ill thought out. We think the way in which they've gone about it is absolutely draconian. And if we could do something differently in Scotland, we would be keen to do it. And we are talking to the BME and others about the possibility of that. But I wouldn't like to raise any expectations because of the strictures that have been put on by Danny Alexander, who I think, you know, is certainly not living up to the spirit of devolution when he says if we choose to do something different in Scotland, they're going to then take the money off us, which would come off frontline services. That's where we're at.
So just to clarify, if you take the top line figure of 80 million that you mentioned there, that would be the cost of covering the contributions. You would then have the equivalent clawback, and therefore it would be 160 million would be the overall cost once you included the clawback. Would that be
well? I think
right?
I think that's probably how it. He hasn't spelled out actually how it would work, but all he said is he will keep back £80 million. If it was £80 million, he would keep that back from the Scottish Government's budget, which. And we have said, obviously, although we would be very keen to do something different, we can't take £80 million off frontline services in the health service in Scotland.
Okay, thank you.
Thanks so much. Just back to a point you raised earlier on, Cabinet Secretary. I won't go into the detail, but you spoke about prescriptions and the effect on individuals. When I was collecting evidence for my palliative care bill, I came across issues in that regard. Be happy to share them with you, have a chat with you. I think it would be very interesting for you to understand exactly the impact on individuals. I would like to raise a question about preventative spending, and by the very nature of preventative spending, we spend money up front now, but we don't see the benefits of that for a considerable time. And I wondered what progress the government are making on preventative spending that you could share with us today.
Can I say a key part, absolutely core to what the health service does is the role of preventive and anticipatory spending. And very good examples, I mean, one that doesn't involve a lot of spending by us is minimum unit pricing. That's a preventive measure. Detect cancer early is a preventive measure. The reasons behind the integration of adult health and social care is preventive as well as about treatment. So there's a lot of what we're doing is preventive, although it's not always described as such, but it has a huge preventive element within it. And obviously the change funds are dedicated prevention funds. And we will use the lessons learned from the change fund to look at how we can do more in terms of prevention and allocating funds specifically to prevention. But can I just also emphasise anticipatory? One of the first things I did when I became Cabinet Secretary is ask Derek and his colleagues to prepare an implementation plan on data mining and data management and micro-targeting. It's very similar to the techniques being used by Barack Obama in his campaign, indeed all the campaigns now in the States. We collect as a health service an awful lot of information about people through our GPs. I'm told that every year in Scotland, a doctor will be seen 6 million times by a patient in the National Health Service in Scotland. There's a lot of data collected, and we can now, with the modern techniques, use that data to try to anticipate particular conditions, who are the most vulnerable people and so on. For example, in Stirling, they're probably the most advanced in Scotland in pulling together the data from all the different agencies. And what they are finding now is that the data is being used for preventative spending because they're able to identify, they're able to anticipate problems before they arise. I've got a meeting tonight between the Chief Medical Officer and the new Chief Constable for Scotland, along with Kenny McCaskill. And the subject of it is how can we pull together so that we identify people, for example, with drink or drug problems or mental health problems before they get into the criminal justice system and try and prevent them getting to the point where they commit crime. Now, if we can do that kind of activity, which, the tools are now available to do that kind of work, that I think would be a revolution in preventive spending and its prevention and anticipation. So every technique, every way of doing it, we're looking at and going to apply. But it's not just doing it ourselves. I think the real benefit of this is doing it with our colleagues in local government, in the police service, and the court service, and right across the entire public sector and the third sector.
Thanks for that. A wee while ago, maybe about 6 months, 9 months ago, Harry Burns came to our committee, and an issue that he raised or informed us about was that we were intervening with women who are leading challenging lives.
Yep.
And there was a support team put in. These were pregnant women, and the support team was put in not when the baby was born, and that was what I would expect to happen. Absolutely. That would be the old-fashioned way of doing it, or is the old-fashioned way, right or wrong. But they were intervening as soon as they identified that the woman was pregnant, and the outcomes from that were quite dramatic in terms of the benefit for the child and for the mother. And the other benefit, if I put another hat on, talking about pounds, shillings and pence and old money, was the health service actually benefited enormously from the aftermath of what would normally happen in these circumstances. So I think that's a really good outcome for preventative spending. So my question is this, that there's some talk at the present time, and I listened to what you said earlier on about caveats. Caveats, you can say anything at the beginning and at the end. It's the bit in the middle that counts, in my view. So the caveat bit, at the present time, people are saying that the government is taking its eye off the ball and maybe listening to the folk with the caveats and putting up the attack on the basis of how much money has been spent now in a service compared to last year. If you're doing preventative spend, it should actually go down at some point because you're front loading. So my question is quite direct to you. Is the government taking its eye off the ball in preventative spending?
No, absolutely not. And in fact, the project you refer to, Family Nurse Partnerships, is a very, very good example of the innovative approach we're taking to prevention. And it's based on the international research that's been led in many ways by Harry Burns, our own Chief Medical Officer, which shows that a child's life chances are largely decided during the 9 months in the womb and the first 6 months of life. And by the end of the 6 months, there are actually chemical changes in the brain resulting from how that baby has been treated both in the womb and during the first 6 months of life. And it shows that, you know, in the first 6 months, first 2 years of life is extremely important in deciding how well, and the period in the womb is the period that decides the life chances of these children. So the Family Nurse Partnership, which is you've described, Gil, is that early intervention with vulnerable young women who have become pregnant, and their partners are involved in this as well, and they get a very substantial support package throughout the pregnancy and throughout the first early months of the child's life. Now, I actually attended the first award ceremony for the parents who are the first to graduate from this. First of all, can I say the dropout rate was extremely low, which in itself is a good indication of how successful the programme is. And two things. Number one is I think this is actually not just of major benefit to the mothers and the partners as well as the children involved in the family nurse partnerships, but what I think is happening is there are already very clear signs that it is beginning to break the generational legacy of problem families. Because we can now see some of the women young women who have gone through this programme are pregnant again, and actually what they have learned in the Family Nurse Partnership programme, they themselves are doing, you know, with their second or third child, their new child, and the you know, it's still in the womb. They're still getting support, obviously, from health visitors and all the rest of it, but there are very, very clear signs that this programme is working extremely well. And that's why we announced a couple of weeks ago that we're rolling it out immediately to another 4 board areas and to the entire country by 2015. And it's a very, very good example of where preventive spending and imaginative, innovative approaches, very targeted, can both prevent and anticipate problems almost before they arise, identify the people who need this kind of service and this kind of support. Now, on the point about we should start to see budgets going down as the preventive measures work through, can I say that two things. First of all, I'm quite happy if the budgets don't go down as long as the preventive measures have the impact on the lives of those children. So I would rather invest that money and know that in 5, 10, 15 years' time, these children will not be truants. They will not end up in the criminal justice system. They will be able to do much better at school than they otherwise would have done without that kind of early month support, and so on and so forth. So I don't think this is a quick fix about seeing budgets going down in the short term. Secondly, where those preventive measures, where they do release cash savings, we are reinvesting those cash savings back into other areas in the health service to improve the service elsewhere. So the whole point is to keep reinvesting so that we make sure that we keep improving the quality and level of service provision in the National Health Service. So it's a much bigger return on the investment, but we won't necessarily reduce the budget. We'll reinvest it in other priority areas where we can. But I think we need to look at this longer term, particularly something like the Family Nurses Partnership. I think there are very many and identifiable and measurable short-term advantages and benefits from the programme, but I think when you measure it over, say, a 20-year period, the benefits will be absolutely enormous, primarily in terms of these human beings will be able to live a much better life, a much more enjoyable life, free of some of the problems that may have occurred had they not this kind of support in their very early period.
Remind the Cabinet Secretary, I think you've got a Cabinet meeting to go to, have you?
I have indeed.
Yeah. Just in terms of the answers, if we're going to get through the questions here. Mr. Feely wants to respond to you, Gil.
Okay. Two very brief points. Firstly, sometimes the benefits of these measures come through quicker than you might anticipate. If we think back to the impact of the smoking legislation, for example, we did not think that you would start to see a difference in people's health as quickly as you did after the smoking legislation was introduced. So we may get some earlier benefits. The second thing I just wanted to very briefly highlight was the prevention programme that was launched last month called the Early Years Collaborative. That's going to use some of the improvement techniques of science that we've been using in patient safety in a multi-agency improvement programme aimed at early years. So it will be aimed at 3 strands, minus 9 months, if you like, pregnancy to 1 month old, 1 month to 3 years old, 3 years to 5 years old, aimed at reducing infant mortality, improving what Harry talks about as attachment, that connection between the child and family, and improving readiness to learn. As far as we know, it's the first big public sector attempt at improving outcomes in this area that there's been. Very exciting initiative, I think.
I think my point was actually to see if you had the balls to keep this going, to be quite frank with you, with the attacks that come on
We have.
in this area. So I would encourage that. But another word you used earlier on was that you used the word anticipate. But what you are anticipating is the things that were in your own control in the budget that we have. And that's what we're talking about.
Yeah.
What my question relates to is what you can't anticipate, what's coming down the road with the cuts that are going to affect us, and what contingency plans is in place, looking at how the health budget is going to be impacted on. What can you do? The word mitigation comes, but it's a word that I think in the real sense is meaningless. But what forward planning are you?
Well, my answer, the core of my answer to that, Gil, would be to quote Nye Bevan, the founder of the National Health Service, and that is to apply the language of priorities. And you clearly, if resources get so tight, and we continue with this agenda of cuts in the long term, then clearly we have to prioritise. We have to prioritise, and the prioritisation has to be on the basis of clinical need. And therefore, in that kind of situation, we would prioritise resources for the greatest areas of need. Need has to be the key criteria. Because it's a National Health Service, clinical need has to be the key criteria by which we allocate resources.
Yeah, thanks for that, Minister. Thank you.
Thanks, Gil. Just quickly, the Cabinet Secretary, you stressed the importance of e-health. Was that an indication we're going to reverse that £1.6 million cut to that e-health?
Well, actually, overall, if you look right across the board, we're actually spending more money in e-health. It might not be under that particular budget line. It's one of these areas that permeates a number of budget lines, but absolutely, we are totally committed to the development of e-health. Grampian has taken a great lead in this. There are other areas involved as well, but it might even be just something as simple. When I did my first annual review, which was at the Western Isles Health Board, one of the points made to me during the lunch break by one of the senior medical people was, one of the ways in which we could save money is if St Andrew's House put in a teleconference system that we could all use and we wouldn't need to travel to Edinburgh as much. So that...
You never had one?
I don't think we have.
I've got a teleconference system.
Oh, right. I thought
that we could all use was I think.
Yes, that's right. So that will not appear. That will not appear in the telehealth budget line.
No.
But it's a very good example of telehealth.
It was a point that we've taken in evidence in terms of the importance. I think everyone agrees with you, the importance of that, about pushing this agenda on. And it was noted the contradiction that we were cutting that budget ahead in 1.6 million or something. Nanette Millen?
If I may, in your answers to Mark MacDonald, Cabinet Secretary, you touched on the third sector. And I think there is a general agreement that the third sector should be involved, should be encouraged to be involved in provision. the NHS. Really my question is enough being done to encourage them? Is there anything you can do to put pressure on the NHS and local government to make faster progress on involving the third sector? That's one point. And the other issue, when we're talking about changes in the NHS, and I'm thinking in particular of the forthcoming integration of health and social care, we keep coming across professional barriers or vested interests, however you like to call it. And I just wonder if you've got any thoughts on how that can be approached, because I think the sort of cultural change is going to be very important if that legislation is going to be effective.
Well, actually, even in answering the first question, I think you could take the example of the integration of adult health and social care, because quite frankly, I think the third sector has a major role to play at every level in that integration agenda. And I think there's clear evidence that in terms of delivery of a whole range of services, third sector organisations can be better at delivery, more effective at delivery, and more cost effective at delivery as well. So I'm very, very committed, and we have the third sector represented on the ministerial group on integration of adult health and social care. And it's for that very reason they need to be heavily involved. They've got huge expertise, huge experience in all of this, and I'm very keen at every level, locally, nationally, regionally, operational level, at strategic level, we involve the third sector. I think you're absolutely right on that. In terms of vested interests, I mean, at the end of the day, we have to take policy decisions based on what's best for the Scottish people, in the case of the health service, primarily what's best for Scottish patients. While we listen to the vested interests and we take into account what they say, at the end of the day, they cannot dictate our health agenda in Scotland. There is an issue, undoubtedly, and which is going to be a challenging issue when it comes to the integration of adult health and social care, and that is marrying the two cultures of the health boards and the local authorities together. Now, actually, where the integration agenda is at its most advanced, for example, in West Lothian, my understanding is that actually that has tended to happen almost much quicker than people anticipated in a much better way. Now, that doesn't mean to say it's going to happen that way across the country. It's something that we all need to work at. But obviously, when you pull two organisations together to work in an integrated fashion, then very clearly we need to be very proactive in making sure that the partnerships need to develop a culture of their own that both health boards and local authorities need to adhere to. So that's a very good point. It's one that we're very conscious of. Our friends and local authorities are very conscious of it as well, and it will need to be worked at. But work at it we will to try and make sure that it's in no way a barrier to success on the integration agenda.
That you said the patient was the most important focus.
Absolutely.
I think that's what we'll look at. Thank you.
Absolutely.
Some questions we could follow up, but we're aware of the time. Drew Smith, followed by Aileen McLeod.
Thank you, Convener. Two brief questions, if I may. First of all, NHS Health Scotland, which is our national health promotion agency, along with Healthcare Improvement Scotland, would seem to me to be two special boards that have got a very particular role to play in terms of preventative health. Why is Audit Scotland expressing concern about consistent underspending in those two boards?
Basically, I think in terms of underspend, sometimes they're more efficient in doing things than they anticipated. And underspend, and I come back to the original point, Drew, we are a national health service, although there are 22 boards, 14 territorial boards and 8 specialist boards, where we don't need as much money in one and we don't spend money just for the sake of spending money, then that resource becomes available for the wider National Health Service. I'm not concerned about underspend per se. I would be concerned if they're underperforming. And I think the reality is if they've been given a budget and they don't need the entire budget, then it's far better to say, well, look, we can free up some of that money for other things. I'm going to bring John in as well into this, but I actually think we need to get out of this culture of thinking you've got to spend every penny, even if it means not spending it as wisely as you you should be doing. I think we've got to get out of that mindset. We've got to get into the mindset is we're all part of a National Health Service, and we should spend the money wherever in the National Health Service we get the best return for it in terms of patient care and achieving our heat objectives and all that.
Doesn't a consistent problem there suggest poor financial planning?
Well, I don't agree with that, actually, but I'll let John deal with that specific point.
No, I don't think it does indicate that. I think we need to put it in context that the figures that have been talked about are quite small figures. I think the key for both those organisations, and we need to remember that HIS is a reasonably new organisation that is developing its strategy and how it's going to deliver that strategy. But one of the key factors that I always look for there is how much of their money they're spending in the indirect patient care services or public services, which is where their focus should be. And that's why I was pleased to see with the Health Improvement Scotland that they have now co-located with the ambulance service in the headquarters of NSS. So they're minimising bureaucracy, minimising some of their backroom services around facilities and other aspects, and directing more of their expenditure directly on to the public services that they should be focused on and are focused on.
From a specific question on to perhaps a slightly broader one, there's a concern identified again in the Audit Scotland report around the 9 boards which are relying on non-recurring funding to break even. I mean, to what extent does that concern you, that is still the case? I mean, I presume that you would, in accepting that we need to get them onto recurring savings rather than just trying to get through each year. Is it the case that the boards have now gone past the easy parts of the savings that they need to make, and in reality, in the next year and years, they are going to be cutting into the quick?
Cabinet Secretary, I know it's a broad question, but a brief answer would appreciate it because we're keen to allow Aileen McLeod in before the evidence session.
Right, okay, fine. Basically, I think obviously as time goes on, it's more and more difficult to identify easy savings. When the savings agenda now has been going for 4 years, at the end of next year, saved nearly £1 billion. I personally don't share the concern about one-off savings. However, I do think we need to recognise that for the foreseeable future, certainly until about 2015-16, it looks as though we're going to continue to be the subject of these spending cuts from Westminster. And therefore, what we are trying to do in an innovative fashion is to make sure that we generate internally within the health service the necessary resources to provide the quality and the level of service we believe is essential in Scotland. That has to, and I think will remain, a combination of recurring efficiency savings and cost savings as well as one-off cost savings. Similarly, as we mentioned earlier, in terms of, say, the property portfolio, if the property market, commercial property market, or even the housing market, because some of the buildings would be suitable for housing, if that improves, then we'll get one-off capital receipts as we sell them. Now, one of the problems we've had in recent years is the property market's been so depressed that the capital receipts that you would normally have expected from surplus properties have not been forthcoming. If we see an improvement in the property market, then that situation will change. So I'm not concerned per se, as long as we can continue to identify the sources of funding we need to provide the quality and level of care that Scotland needs.
Just very, very briefly, it's a fair point that Audit Scotland make. We keep a very close eye on the level of dependency on non-recurrency. We are a £12 billion organisation, and the level it sits at, 20-30 million, is less than sort of 0.5% in that context. And also the same with efficiency savings. The people will develop efficiency savings in a year. They'll get the full year benefit in the following year, but there may be some non-recurrent support required in the current year. And we look at the level of that, and we do that on a board-to-board basis, through annual reviews, through detailed month-to-month discussions and mid-year reviews.
Aileen McLeod.
Thanks very much, Convener. Cabinet Secretary, one of the areas of the draft budget that we haven't really as a committee touched upon yet concerns the health research and innovation side, which clearly has an important role to play by way of maximising the outcomes for patient care in terms of how we turn clinical research into clinical practice through the support that we give to our universities, our research community and our business sector, and how we can improve health promotion and disease prevention, understand disease and improve our diagnosis, as well as develop better preventative medicines, etc., etc. Now, the European Commission has identified healthy and active ageing as one of its global challenges. So does the Cabinet Secretary therefore welcome the support, in particular the financial support, that is likely to be forthcoming under the future EU Research and Innovation funding programme for 2014 to 2020? That's obviously it's Horizon 2020, where €80 billion has been proposed to support that programme. This obviously depends very much on what comes out from the current ongoing EU budget negotiations in Brussels. So do you see an opportunity to be able to utilise that particular measure as a support for research and innovation in this area in Scotland?
Well, one of my jobs is to chair the Life Sciences Alliance. As you know, the Scottish Government has designated life sciences as one of the three major target growth areas in terms of our economic development strategy. But also, in terms of our health strategy, research and development are absolutely crucially important. And the Office of the Chief Scientist for the Health Service, Andrew Morris, has been doing a great deal of work on both the research side and working with companies to try and get more of the development done in Scotland. And as you know, we've had recent announcements of very successful work being completed with companies now doing clinical trials in Scotland and seeing Scotland as a hotbed for growth in this entire sector. So I absolutely welcome the prospect of additional funding from the European Union. Scotland, given our research base and given the fact that we've got so many high-quality universities, I think 3 of our universities are in the top 200 in the world. I don't think even Germany's got 3 universities in the top 200 in the world. And particularly centres of excellence, for example, my own old university, the University of Dundee. It used to be a centre for training brilliant young economists. Now it's a centre for training. Now it's a centre for training brilliant young medics and life scientists, and particularly, its role in cancer research. So absolutely, we will be very proactive in pursuing that agenda at the European level as well as within Scotland.
Okay, thanks very much.
Okay. No other questions? Thanks very much. Thank you, Cabinet Secretary, and your colleagues for your attendance this morning and the information provided. Thank you. We may wish to, given that we squeeze it and whatever, there may be other additional questions that we can write to you about.
No problem.
Supplementaries.
No problem.
We'll do that. Thanks.
Any information, we're glad to provide it.
Thank you. Suspend the meeting. Yeah, we'll suspend at this point until we get set up. We now move to item 2 and reconvene the meeting to move to stage 2 of the Social Care Self-Directed Support Scotland Bill. And can I welcome Michael Matheson, Minister for Public Health. Welcome, Minister. And his officials who accompany him this morning is Jean McClellan, Head of Adult Care and Support Division, Craig Flunkert, Bill Team Leader, Kirsty McGrath from the Legal Directorate, and Ian Shanks from the Office of Scottish Parliamentary Council. So we now move that the question is that Section 1 be agreed to. Are we all agreed?
Agreed. Yeah.
Thank you. Can I call Amendment 1 in the name of the Minister in a group on its own? Minister to speak and to move the amendment.
Thank you, Convener. I'll speak to Amendment 1 in my name. Throughout the passage of the bill, I've been keen to work with committee members to strengthen the bill where appropriate. That's why I'm pleased to have followed the committee's recommendation that consideration should be given to making the principles of independent living already explicit in the bill more explicit by way of direct reference on the face of the bill itself. Indeed, I recall that it was Richard Simpson who first raised this question during the course of my Stage 1 evidence session to the committee. The recommendation made by the committee in its Stage 1 report was based on the evidence received from groups representing the interests of people who have disabilities. This includes groups such as Independent Living in Scotland, Self-Directed Support Scotland and the Scottish Consortium of Learning Disability. There have been challenges in shaping independent living principles into legislative propositions and fitting them into the structure of the bill. For example, the one key element of independent living, choice, is already dealt with by the provisions of the bill enshrining choice and by the general principles in Section 1(2) of the bill. However, I'm confident that Amendment 1 succeeds in introducing core principles of independent living onto the face of the bill, being treated with dignity and having your desire to participate in community life respected. I'm confident that this amendment will help to ensure that the existing principles contained within Section 1 of the bill, principles which are largely concerned with the process of self-directed support, are accompanied by one which defines the end goal of the person's social care assessment and care and support plan. Self-directed support processes need to be informed by that end goal. The Independent Living Principle will join the existing 1968 Act duty on local authorities to promote social welfare, and in many respects it will reinforce and provide a modern interpretation of that end goal for social care. And as with existing principles in Section 1, Amendment 1 will help to guide practitioners as they implement the various duties and powers contained elsewhere in the bill and the interaction with social care assessments and support provision. I move Amendment 1 in my name and ask the committee to support this amendment.
Thank you, Minister. Any other member wishing? Richard Simpson.
Very briefly, Chair, and welcome very much this amendment. As the Minister alluded to, I did indicate that I thought that this was an important additional expansion of the general principles, which would actually incorporate some of the evidence we had from those who were concerned to ensure that the principles included more clear aspects of independent living, and I very much welcome the Minister's amendment.
Thank you. Any other members? Nanette Millen.
Just very briefly to say that I too very much welcome this addition to the bill.
No other members. The question is then that Amendment 1 be agreed to. Are we all agreed? Agreed. Thank you. The question is then that Section 2 be agreed to. Are we all agreed? Agreed. Thank you. Can I call Amendment 2 in the name of the Minister, grouped with Amendments 3, 21, 4, 5, 6, 22, 7, 7A, 11, 11A, 12, 12A and 20. Minister, to move Amendment 2 and speak to all amendments in the group.
Thank you, Convener. I'll move Amendment 2 and speak to the other amendments in the group. As committee members will be aware, Section 3 of the bill defines the options for self-directed support, the options which will be available to an individual when they are eligible for social care. In the bill introduced into Parliament, the direct payment option was described as a payment of relevant amount by a local authority to a supported person. My Amendment 2 through 7 and 11, 12 and 20 are in response to concerns raised by stakeholders through the Bill Steering Group that a transparent budget is a vital component not just of the direct payment but across all of the options which may be chosen by an individual. It is in response to these concerns that Amendments 2 to 5 are introduced the element of a relevant amount into the description of options 2, 3 and 4 in Section 3 of the bill. When considered alongside current option 1, the direct payment, this will mean that all 4 options for self-directed support will include a reference to a transparent financial resource. Amendment 6 makes the necessary consequential amendments to the definition of relevant amount. It removes the current reference to the direct payment and replaces it with a more generic reference to support, something which is meaningful to all 4 of the options. Amendments 7, 11 and 12 impose a further duty on local authorities to inform the individual, in other words, the child, the parent, the adult or the carer who is being provided with support, of the amount of funding available under the options and the period to which that funding relates. This ensures that there is transparency about the funding available regardless of whether it is a service that will be arranged by the local authority or a direct payment or an individual service fund which the person may direct. Turning to Richard Simpson's amendments, Amendment 21 seeks to make clear that the budget allocated for a person's support under option 2 can be managed by a third party. In other words, the budget can not only be managed by a local authority, but could be delegated to a third party, a provider organisation, to manage with the consent of the supported person. This, in effect, the same as a third party direct payment, where a sum of money is paid to someone other than the local authority or the supported person. We intend to make provision for this in the regulations using the regulation making powers contained in Section 13 of the bill. This will allow for a more flexible approach as some of those third parties may be providers, others may not be described as providers. In other words, they may include brokerage organisations or indeed individuals. Statutory guidance will also make clear that the budget can be delegated to a third party and that this can include a provider organisation. I'm clear that it's unnecessary to amend the bill to add detail that will be better situated in the regulations. Moving to Amendments 22, 7A, 11A and 12A, I suspect that by proposing these, Richard Simpson is attempting to address the unfairness in setting the rates between various options. However, it's not appropriate for government to restrict flexibility without a full understanding of the potential consequences in doing so. The guidance we will give full consideration to issues around commissioning, procurement and finance, which will lead to discrepancies in the allocation of resources to be better addressed. Furthermore, the amendments which I have brought forward will, as I've said, increase the transparency of the choices available to individuals, which itself should lead to fairer and a more open system. I therefore urge Richard Simpson to not move any of his amendments, but if he is minded to do so, to urge the committee to reject them. I move Amendment 2 and ask the committee to support the other amendments in my name.
Simpson to speak to Amendment 21 and other amendments in the group.
Can I, Chair, begin by welcoming the amendments that the Government have put forward, because that does increase the transparency, and I think that that is a very important first step in assuring people who are applying for direct support as to the money that they would get under the different options. So I think that that's extremely welcome. However, there are concerns which are moved in my amendments. If I can deal with Amendment 21 to begin with. In this section, we are trying to put on the face of the bill what is actually in Section 23 of the Policy Memorandum, where it indicates that the resource can remain with the local authority or can be delegated to a provider to hold and distribute under the individual's direction. And the recommendations that we've had from CCPS and others involved in social care is that they would like to see that on the face of the bill. I think that is very important. It is contained in the government's own policy memorandum, and therefore I think having it on the face of the bill does not in any way restrict the process. It does augment, however, and enforce the fact that the third sector providers, those involved in it, under the agreement of the supported person, may in fact act in that way. I realise that's not banned at the moment. I realise that it can be done by regulation, but I believe that it should be on the face of the bill, and I will be pursuing that amendment. The Amendment 22 is dealing with the fact that the difference between the options, which are now going to be transparent if we pass the government's amendment, should not be automatically assumed by the local authority to be less under option 1 or option 2. We received evidence as a committee convener, as you know, that there was some indication that where direct payments were being made, that these were already less than the payments under option 3 and 4. And therefore, this is merely saying that there should be not an automatic assumption. The importance of that word automatic cannot be overstressed, because there may be circumstances in which it is necessary and appropriate for the local authority to offer different options under this. They will be transparent under the government's amendments. Under my amendment, they will now not be automatically different. Under Amendment 7A, which is linked to 11A and 12A, the local authority will then be required to provide the reasons in writing as to why there is a difference between these options. Now, I may illustrate a case in which that is a potential possibility. Let us take a day centre that is currently being run by the local authority, which has 15 people attending it. With direct payments being offered, 5 persons might opt out of that day centre. This would clearly put considerable constraints upon the local authority in terms of being able to sustain that day centre for the remaining 10. The unit cost, in other words, might rise. It is important, however, that as part of this whole process, we drive efficiency in the system. And that means that the unit cost, we should understand if that unit cost has to rise, why it has to rise, what approach the local authority has taken to try and improve the unit costs and make them less, so that the majority of the funds can actually be transferred to those undertaking self-directed care. So I believe that what this does is builds on the government's own amendments. It ensures that the supported person and the individual that we'll come to later who may be supporting that person seeking supported care, they will see this clearly. They will understand, hopefully, the local authority's reasons for varying it, but it will not be an automatic variation. I think these amendments lend considerable additional clarity, and I will be pursuing all 3.
Any other members before I ask the Minister to wind up? Bob Doris?
Thanks, Convener. First of all, I'd like to welcome what I think were necessary amendments in Amendment 2 and 7 in terms of making sure that all 4 option choice under self-directed support are clearly communicated to the person seeking to exercise them. I think that would have been remiss for that not to have been put on the face of the bill, so I'll be keen to support those. In terms of Richard Simpson's Amendment 7A and 22, the concern I have is it seems to be hinting towards the resource allocation that's formulated following the care assessment, and this bill, of course, doesn't necessarily touch on that in any way. I see what Richard Simpson's trying to achieve, but I would like to think that any inappropriate assessments that may take place would be picked up by the care inspector during any routine assessments they would do of the local authority. So for that reason, I won't be supporting 7A or 22. In the case of 21, I will, of course, I'll vote against that just now, but I do again want to reinforce Richard Simpson's view that third-party providers in the voluntary sector should be seen as key players in terms of being other providers rather than just the local authority, but I'll await to see what appears in guidance in relation to that.
Thanks, Bob. Any other members?
Can I ask in terms of process, Convener, do I get the opportunity to respond to points that are made against my amendments?
No. I now call on the Minister to wind up.
Thank you, Convener. I think, although I understand the objective that Richard Simpson has with regards to his amendments, I do think that the government amendments do bring in greater transparency to the process, which I think is extremely valuable and will assist in helping to give people greater clarity around decisions that are made by local authorities. I do remain of the view that the wider issues that Richard Simpson has raised concerns about are better dealt with through guidance which will accompany the bill. And I've stated very clearly that we will give full consideration to issues around commissioning, procurement and finance, which can lead to discrepancies on allocation of resources as part of the guidance which will accompany the bill. Alongside that, where amendment also brings in, where under regulations and under guidance, we will also make it very clear about the ability of a third party to be able to hold an individual budget on someone's behalf as well. So I do believe that guidance provides us with greater flexibility in dealing with these issues, and I've given a clear commitment to the committee that we will give consideration to these matters as part of the guidance that will go with the bill.
The question is then that Amendment 2 be agreed to. Are we all agreed? Agreed. Can I call Amendment 3 in the name of the Minister, already debated with Amendment 2? Minister, to move formally?
Moved.
Thank you. Question is then that Amendment 3 be agreed to. Are we all agreed? Agreed. Thank you. Call Amendment 21 in the name of Richard Simpson, already debated with Amendment 2. Richard Simpson, to move or not move?
Move.
Move. The question is then that Amendment 21 be agreed. Are we all agreed? No. We have a division. Can I have a show of hands for the amendment, please? 1, 2, 3, 4, 5. Those against? 5. No abstentions? That's not agreed. The amendment is not agreed to. Okay. We move on to call amendment in the name of the Minister, already debated with Amendment. You didn't say 4. Pardon? Call Amendment 4. Oh, call Amendment 4 in the name of the Minister. Sorry about this. There's all the excitement about that division there. Call the Amendment 4 in the name of Minister, already debated with Amendment 2. Minister, to move formally? Thank you. The question is then that Amendment 4 be agreed to. Are we all agreed?
Yes.
Call Amendment 5 in the name of a Minister, already debated with Amendment 2. Minister, to move formally? Thank you. Question is then that Amendment 5 be agreed. Are we all agreed? Agreed. Thank you. Call Amendment 6 in the name of the Minister, already debated with Amendment 2. Minister, to move formally?
Moved.
Question is then that Amendment 6 be agreed to. Are we all agreed? Agreed. Thank you. Call Amendment 22 in the name of Richard Simpson, already debated with Amendment 2. Richard Simpson, to move or not move? The question is that Amendment 22 be agreed to. Are we all agreed? No. No, we have a division. Can I have a show of hands, please, for the amendment? 4. For those against? No abstentions. The amendment is not agreed to. Call Amendment 7 in the name of the Minister. The question is then that Section 3 be agreed to. Are we all agreed? Yes. Call Amendment 7 in the name of the Minister, already debated with Amendment 2. Minister to move formally. Move. Thank you. Call Amendment 7A in the name of Richard Simpson, already debated with Amendment 2. Richard Simpson to move or not move? Moved. Question is then, Amendment 7A be agreed to. Are we all agreed? No. We have a division. Can I? Yes. Can I have a show of hands, please, for the amendment? 7A. Yeah. For the amendment. Those against? No abstentions. The amendment is not agreed to. Call Amendment 23 in the name of... Oh, yeah.
We appear not to have formally agreed Amendment 7. The Minister moved it, but I don't recall us being asked to agree it. The Minister moved Amendment 7 and we went straight on to...
The question is that Amendment 7 be agreed to. Are we all agreed?
Agreed.
The question is that Section 4 be agreed to. Are we all agreed? Thank you. Assistance call Amendment 23 in the name of Richard Simpson, group with Amendments 8, 24, 9, 10, 27, 35, 14, 36, 15, 16 and 39. Richard Simpson to move Amendment 23 and speak to all amendments in the group.
Thank you, Convener. The amendments 23 linked to Amendment 27, 35 and 39 are amendments that have been sent to us by the Law Society. And the reason for it is that they believe that by putting into this section physical and mental disability, this actually has the effect of creating an ambiguous and incorrect notion that Section 5 should be applied where the assistant person does not have the capacity by reason of mental disorder or difficulties in communicating due to physical disability. The removal of those terms actually broadens it and means that anyone who requires assistance, the local authority should have to provide that assistance. So it does allow for a broader definition. The consequence of that is seen in Amendments 27, 35 and 39, which either repeat that, the Amendment 23, or remove the need for the mental health definition from the bill, because once that's the initial terms of mental and physical disability are removed, there's no need for a definition to go in. Turning to Amendment 24, this amendment, which refers to the Adults with Incapacity Act, and I'm sorry that it's written in the form of a double negative, in other words, not incapable, but that's the way that you have to write it because the adult bill was adults with incapacity, not adults with capacity. So that's just a hangover from our first session of legal work on this committee, which I was actually involved in, I think along with the Minister, actually. The Society here was concerned that the current wording of the proposed Section 5.2 does not place any obligation on the authority to ensure that the assisted person has the capability and capacity to make a decision. The suggested amendment will place this obligation on an authority and ensure a safeguard against the appointment of assistance to a supported person who lacks capacity. Without the proposed amendment, the Society is concerned that there will be a risk that the procedure under the bill may be used for people who lack capacity. So the effect of this amendment would be to add conditions that must be satisfied and to determine if assistance should be provided to the supported person. The amendment 36, consequentially upon that, is actually dealing with the question of competence and simply says that if the local authority is satisfied that the supported person is not incapable, then they can go ahead with the assessment side. So that deals with another section of the Act dealing with assessment, so it's a similar amendment to the earlier ones. I acknowledge the amendments 9, 10, 14, 15 and 16 in the name of the Minister, which I think are helpful amendments, which I welcome.
Minister to speak to Amendment 8 and other amendments in the group.
Thank you, Convener. It feels like only yesterday we were dealing with the Adults with Incapacity Act, I should say. Can I respond to Richard Simpson's amendments, and I will also speak to Amendments 8 to 10 and 14 to 16, which are in my name. Richard Simpson's Amendment 23 and 35 remove the reference to because of mental disorder or difficulties in communicating due to physical disability. This widens the effect of Section 5 and 15 to allow assistance to be provided to anyone who might need it. This, however, contradicts the policy intentions of Section 5 and 15, which is to underpin very specific types of assistance, in particular assistance that may be required by people who have a mental disorder or a difficulty in communicating. Section 5 and 15 are not intended to provide general assistance to all social care clients. I recommend that this focus is retained within Section 5 and 15 of the Bill. Amendments 24 and 36 add a detailed prerequisite that the local authority must be satisfied that the supported person has capacity to agree that another person should be involved in assisting them in making decisions about relevant matters and making a choice of one of the options prior to identifying someone who could assist them. While I would agree with the broad aim that Richard Simpson has in mind, namely to underpin positive social work practice, we should bear in mind that Section 5 and 15 do not provide for a formal appointment process where individuals may make decisions on another person's behalf. It would be appropriate, however, and I can give Richard Simpson a commitment today to use the powers provided elsewhere in the Bill to provide clear and unambiguous guidance to local authorities on this matter within statutory guidance, and I fully intend for the guidance to cover these important good practice principles. If I can now turn to my own amendments 8 to 10 and 14 to 16. Amendments 8 to 10 and 14 to 16 come partly in response to a concern from the Law Society, the Mental Welfare Commission and the Office of the Public Guardian in their evidence to this committee. The committee, in its Stage 1 report, asked the Government to consider their concerns. It is in response to the committee's request that I have lodged this group of amendments. Amendment 9 and 15 are have exactly the same purpose and effect. All that Amendment 9 relates to is assistance in making the choice in relation to Section 3 of the Bill. Amendment 15 relates to assistance to complete the initial assessment of social care needs. Both will ensure that local authorities must have the supported person's consent to the individual who may have been identified to assist them in making decisions or in communicating their decisions. This reinforces the position that assistance from other individuals under Section 5 and 15 is only in relation to supported people who have capacity. The supported person must agree to any assistance in making decisions being provided by another person or persons. At the point of consent, the supported person would demonstrate that he or she has capacity, and I would hope that this would deal with the concerns that Richard Simpson is seeking to address. The provisions on assistance cannot be used where there is an appointed proxy under the Adults with Incapacity Act, which the Bill currently defines as a guardian or a welfare attorney. Amendment 8 and 10 and 14 and 16, following discussions with stakeholders who queried why the list of legal proxies was restricted to welfare attorneys and why it did not extend to continuing attorneys as well. I agree with the conclusion that it is necessary to add an explicit reference to continuing attorneys, and so Amendment 8 and 10 and 14 and 16 have been lodged to rectify this omission. They add a reference to a continuing attorney to the list of individuals whose presence would disapply the assistance provisions. In conclusion, Convener, I would urge the committee to support Amendments 8, 9, 10, 14, 15 and 16 and ask Richard Simpson to withdraw Amendment 23 and not to move the other amendments. However, if he is minded to do so, I would urge the committee to reject these amendments.
Thank you. Any other members at this point? I'll go to Richard Simpson to wind up.
First, can I deal with Amendments 8, 10, 14 and 16 and welcome the addition of the continuing attorney. I think that that's a logical and welcome step. Amendments 9 and 15, again, ensuring that the supported person agrees is I think, a pretty important amendment, and I welcome the fact that the government has listened to that. However, although it may seem to be, at first sight, clear that someone who has not got capacity should not be invited to be the person assisting the supported person, that is not clear on the face of the bill, and I think that it should be. Putting it into statutory guidance would be welcome, and if my amendment is to be defeated, then that may be something that we will look at to see whether that would be acceptable to those who are supporting this amendment. But at the moment, I will be moving that amendment because I think that it is important that it should be on the face of the bill, and therefore leaving out the mental and physical disability and broadening that term is I think is something which is important. The supported person, if the local authority should, as part of their assessment, initiating that assessment, they should undertake a view, they should reach a view as to whether that individual actually requires additional assistance to be able to actually make informed decisions. That's not the same as capacity. That is something that's saying that they may have communication difficulties, or they may express a wish because of other vulnerabilities that they wish to have a supported person. So I believe that actually having that in there in a broader form, as the Law Society has suggested, is entirely appropriate. So I will be moving the amendments in my name.
Okay, the question is then, Amendment 23 be agreed to. Are we all agreed? No, we have a division. All those in support of the amendment, please show. 1, 2, 3, 4. All those against? 1, 2, 3, 4, 5. No abstentions. The amendment, therefore, has not been agreed to. Call Amendment 8 in the name of the Minister, already debated with Amendment 23. Minister, to move formally.
Moved.
Thank you. The question is then that Amendment 8 be agreed to. Are we all agreed? Thank you. Call Amendment 24 in the name of Richard Simpson, already debated with Amendment 23. Richard Simpson, to move or not move? Move. Question is then that Amendment 24 be agreed to. Are we all agreed? No, we have a division. All those in support of the amendment, please show. 1, 2, 3, 4. All those against? 1, 2, 3, 4, 5. The amendment, therefore, is not agreed to. Can I call Amendment 25 in the name of Richard Simpson, grouped with Amendment 26, 37 and 38. Richard Simpson to move Amendment 25 and to speak to all amendments in the group.
Amendment 25 is another amendment which we received from the Law Society, who are concerned that the current bill does not provide the necessary safeguards or place an obligation on an authority to protect against undue influence being exerted over an assisted person. This amendment will mean that the authority must take reasonable steps to ensure that any person appointed to assist will be suitable in accordance with Section 5, subsection 5, which is proposed. Now, to take an example, that we have had cases in the past where relatives have been acting in a manner which has been substantially over-restrictive on individuals who have capacity. We're not talking about people here who may, through learning disability, have incapacity, and they would be treated differently. But those who are protected differently. But this provides a protection whereby the local authority must ensure that that individual is going to not exert an undue influence and overly restrict that person and use the funds in a way which would be inappropriate. The Amendment 26 is a consequential amendment which lays out how a suitable person can be identified. They must be satisfied and have regard to a variety of conditions which are laid out in Amendment 26. Amendment 37, Amendment 37 and 38 simply repeat Amendments 25 and 26.
Any other members at this point? No other members? Minister?
Thank you, Convener. I'll respond to Richard Simpson's amendments. The Bill Section 5, subsection 4A requires the authority to take reasonable steps to identify persons having an interest in the care of the supported person. Richard Simpson's amendments 25 and 37 change this to a person who the authority considers suitable. And amendments 26 and 38 provide various tests against which the person's suitability should be measured. While I would agree with the broad aim that Richard Simpson has in mind, namely to underpin positive social work practice, we should bear in mind that Section 5 and 15 do not provide a formal appointment process where individuals may make decisions on another person's behalf. It would be appropriate, however, and again I can give Richard Simpson a commitment today to use the powers provided elsewhere in the bill to provide clear and unambiguous guidance to local authorities on this matter within statutory guidance, and I fully intend for this guidance to cover these important good practice principles. I would therefore urge Richard Simpson to withdraw Amendment 25 and not to move the other amendments in this group. If he is not minded to do so, I would urge the committee to reject Amendments 25, 26, 37 and 38.
Richard Simpson to wind up.
Guidance is guidance. We have had cases in Scotland of relatives having undue influence upon vulnerable relatives. I believe that it is imperative that we have this on the face of the bill in order to ensure that the local authorities actually make sure that this situation does not arise. I am fearful that we may have future scandals if this is not the case, and therefore I would urge the committee on this occasion very strongly to support the amendments in my name, which I will move.
The question is then that Amendment 25 be agreed to. Are we all agreed? We have a division. All those in support of the amendment, please show. 1, 2, 3, 4. All those against? The amendment has not been agreed. Call Amendment 9 in the name of the Minister, already debated with Amendment 23. Minister, to move formally. Moved. Thank you. The question is then that Amendment 9 be agreed to. Are we all agreed? Thank you. Call Amendment 26 in the name of Richard Simpson, already debated with Amendment 25. Richard Simpson.
Not moved.
Not move. The question...
No, he's not moved it, so we just skip over go to that one.
We go over jump, yeah. Can I call then Amendment 10 in the name of the Minister, already debated with Amendment 23. Minister, to move formally. Moved. Thank you. Question is then that Amendment 10 be agreed to. Are we all agreed? Thanks. Call Amendment 27 in the name of Richard Simpson, already debated with Amendment 23. Richard Simpson, move or not move?
Moved.
Move. Question is then that Amendment 27 be agreed to. Are we all agreed? No. We have a division. All those In support of the amendment? 4. All those against? 5. The amendment is not agreed. The question is then that Amendment 5, Section 5 be agreed to. Are we all agreed? Call Amendment 11 in the name of a Minister already debated with Amendment 2. Minister to move formally. Thank you. Call Amendment 11A in the name of Richard Simpson, already debated with Amendment 2. Not move. The question is then that Amendment 11 be agreed to. Are we all agreed? The question is that Section 6 be agreed to. Are we all agreed? Thank you. Call Amendment 12 in the name of a Minister already debated with Amendment 2. Minister to move formally.
Moved.
Thank you. Call Amendment 12A in the name of Richard Simpson, already debated with Amendment 2. Richard Simpson to move or not move?
Moved.
Not move. Question is then that Amendment 12 be agreed to. Are we all agreed? Thank you. Call Amendment 28 in the name of Mark MacDonald, group with Amendment 29. Mark MacDonald to move Amendment 28 and to speak to the other amendment in the group.
Thank you, Convener. I'll keep this pretty short and sweet. Amendments 28 and 29 follow on from conversation I had with Bernardo's and relate to the United Nations Convention on Rights of the Child, Article 12 specifically, which assumes that all children have the right to be heard with no age limit applied and no definition of the age of maturity of the child. I believe that the fairly small textual amendment that is made at Amendment 28 will reinforce that principle within the legislation, and as a knock-on consequence of that, Amendment 29 is moved because it therefore renders the following subsection to be superfluous with that change.
Thank you. Any other members? No other members? Minister?
I would support Mark MacDonald's amendment on a child's involvement in decisions about self-directed support options when these directly affect a child. Scottish ministers believe it is right that all children should have the opportunity to express their views on how they lead their lives. These provisions should encourage professionals to give weight to the views of younger children where there is a considered need for appropriate course of action. I believe that this is very much in keeping with the principles of the bill and that all people should be involved in decisions about their support. I therefore urge the committee to support Amendment 28 and 29.
Thank you. Mark MacDonald to wind up.
I don't think I have anything further to add beyond my opening remarks, Convener.
You're pressing that. The question is then that Amendment 28 be agreed to. Are we all agreed? Agreed. Call Amendment 29 in the name of Mark MacDonald, already debated with Amendment 28. Mark MacDonald to move or not move?
Moved.
Thank you. The question is then that Amendment 29 be agreed to. Are we all agreed? Agreed. Thank you. Question is then that Section 7 be agreed to. Are we all agreed? Agreed. Call Amendment 30 in the name of Alison McInnes, grouped with Amendment 31. Alison McInnes to move Amendment 30 and speak to other amendment in the group.
Thank you and good morning, Convener. I hope these two amendments are uncontentious. My intention is to make it clear that the provision of information should be tailored to the individual's needs. If there's truly to be choice, then it will not be enough to just hand out a leaflet explaining what people's options are. The intentions of in the bill, of course, are good, but I hope this strengthens it by ensuring local authorities take a person-centred approach to the provisions. And I move Amendment 30. Turning to Amendment 31, there's no doubt that in many cases people will benefit from having more control over their care or the care provided to their children. But for many people, and while this amendment hopefully would assist everyone, I'm thinking particularly of parents caring for a child with complex needs within a family. And those parents, as we all know, are involved in care 24/7 and are often exhausted by the demands of care. It might well be that self-directed support would provide a more responsive care package for them, but the requirement to set up recording mechanisms, budgets or secure the services themselves would be a burden too far for some of these parents. And this amendment would ensure that local authorities provide the proper support to people to allow them to really have a choice. And I should note that I'm grateful to Quarriers for working with me on drafting up this amendment.
Any other members? Minister.
Thank you, Convener. The aim of the bill is to ensure people have informed choice about self-directed support, not only in understanding what the 4 options are, but also in understanding which of these options will best meet their needs. Amendment 30 from Alison McInnes would make it explicit on the face of the bill that the explanation of the options for self-directed support must relate to each person's circumstances. Section 82A already requires the local authority to explain the nature and the effect of each option. The nature and effect of each option and what each option means in practice will vary from person to person. I consider that this point is already covered and that this level of detail is appropriate for the statutory guidance which will accompany the bill. Access to practical information and assistance is a significant element in shaping a successful support package. Amendment 31 from Alison McInnes would place a specific example of a person who can provide a particular type of assistance on the face of the bill. Section 82C already requires the local authority to provide a supported person with information about other organisations that can provide information and assistance, and in particular, information about managing support. This is a broad provision, and I consider that information about managing support would include advice about structuring and commissioning a package of support. In addition, Section 82B requires the authority itself to give the supported person information about how to manage the support. Again, this is a broad provision which would cover all aspects of advice about managing support, including those specifically listed in Amendment 31. And these provisions will be underpinned by statutory guidance which will provide further detail about the level of support and advice a person should expect to receive. I therefore think that Amendments 30 and 31 are not necessary and their sentiments are best covered in statutory guidance accompanying the bill. I do not support Amendment 30 and 31 and would ask Alison McInnes not to press them.
Alison McInnes, to wind up, press or withdraw.
And I hear what the Minister says, but for truly informed choice, I would like to see these assurances on the face of the bill. Ensures local authorities, I suppose, have no wriggle room in interpreting how they take forward the regulations. So I will push the amendment.
Okay. The question is then that Amendment 30 be agreed to. Are we all agreed? I took my, because I had my hearing thing here and I've taken that out now because it was taking too much interference. Can I do that again? The question is that Amendment 30 be agreed to. Are we all agreed? No. We have a division. Can I have a show of hands in support of the amendment, please? 1, 2, 3, 4. All those against? The amendment is not agreed to. Call Amendment 31 in the name of Alison McInnes, already debated with Amendment 30. Alison McInnes, to move or not move?
Move.
The question is then that Amendment 31 be agreed to. Are we all agreed? No. We have a division. Can I have a show of hands for all those who support the amendment? 1, 2, 3, 4. All those against? 1, 2, 3, 4, 5. The amendment is not agreed to. Question is then that Section 8 be agreed to. Are we all agreed? Call Amendment 32 in the name of Drew Smith. And a group on its own, Drew Smith to move and speak to amendment. Other members will get an opportunity.
Thank you, Convener. The purpose of my Amendment 32 is to include provisions for independent advocacy and specifically to enshrine a right of access to independent advocacy on the face of this bill. And bring this amendment forward, I should first be clear about what independent advocacy is and is not. The Independent Advocacy Alliance, in their submission on this subject, and I think in direct response to the Minister's point during the Stage 1 debate, when he said that impartial information and advice are what is crucial here. They say, and for the benefit of the report, this is from their briefing of the 17th of October, they say that while the bill contains duties on councils to signpost people to sources of impartial advice, this would by its nature not include advocacy. Independent advocacy should never be impartial. The point of independent advocacy is that they are there to stand firmly on the side of the individual, listening to them and supporting them to make their own decisions and choices. While an advocacy organisation will support an individual to gather all relevant information, advocacy will not offer advice on choices. The reason why I think this is important in the context of this bill on self-directed support, where I think made well by Pam Duncan in evidence to the committee, and again I would quote, the provisions in the bill should be as strong as those in the Mental Health Care and Treatment Scotland Act 2003 that give a right to independent advocacy. That is our view, not just because the default position is choice and therefore people must have support in order to make that choice, but because of the intricate situations that disabled people and other care service users experience, it is important that we make the bill strong on those aspects. This is not likely to be required by everyone making use of the provisions for self-directed support outlined in this bill, and I would go further and say it would not be necessary or desirable, or again to quote from the evidence we heard, proportionate for everyone to do so. So to be clear, the purpose of this amendment is not to create compulsory advocacy, rather it is simply to ensure that there is a guarantee of an opportunity if it is required by those outlined in subsection 1. Convener, no one around the table, including the Minister, I'm sure, disputes that advocacy has a crucial role to play in the increasing take-up of self-directed support. The question is only one of whether we acknowledge that a right to it is more likely to ensure that all those who need it can get it, regardless of whether advocacy services have and will in the future be well supported in all areas of Scotland. Some local authorities have developed self-directed support have placed a strong emphasis on advocacy already, particularly when it comes to needs assessments, but we do know from evidence that others have not. I hope that members will support Amendment 32, and if the Scottish Government are not minded to do so, I hope the Minister will indicate whether he'd be willing to have any further discussion about alternative wording which might satisfy any concerns that the Government has, but also address the concerns that I, and indeed I think many others through Stage 1 raised.
Mark MacDonald.
Thank you, Convener. I can understand the intention which lies behind the amendment from Drew Smith. The only difficulty, well, I'd say the only difficulty, but the difficulty that I would highlight at the present moment is that it appears very much that it sets in train a process which may at the end be unnecessary insofar as it requires the local authority to secure availability of independent advocacy services before actually determining whether or not the individual A already has advocacy services operating on their behalf, or indeed B whether or not they wish to make use of independent advocacy services, because then part B is about taking appropriate steps to ensure those persons have the opportunity of making use of those services. So it may be that they do not wish to utilise that opportunity, or it may be that that opportunity is not necessary, but the local authority will still have had to go through the process of securing the potential independent advocacy service. And I think there's a little bit of cart before horse within the wording of that amendment, and I don't think I could support it on that basis.
Boris?
Thanks, Convener. I listened with interest to Drew Smith's comments. I have some sympathy for what Mark MacDonald said in terms of the wording of the amendment, but I also do have quite a strong sympathy for the distinction that Drew draws between advocacy, advice and information, and I think some of his points were well made. I'm not minded to support the amendment at the moment, but I will be quite keen to listen to what the Minister has to say in relation to this and remain open-minded to how we could take this forward in the future.
Gil Patterson.
Yes, some good points made from all the contributions. My concern in this is, I think it touches on what Mark MacDonald was saying, that there's a finite cost. There's only so much money we've got. And what I'm saying is a bureaucracy put in place for something that we don't need. People can ascertain services at the present time, and implicit in this amendment, unless someone can tell me different, would be a need to provide for the service, even although the majority of people won't go and get it. So that, in other words, what I'm saying is that there is capacity in the system at the present time to look after those who need it, whereas building up an additional bureaucracy, I think, doesn't make any sense.
I've listened to all the contributions with interest. I think many stakeholders we've heard from during the course of this passage of this bill have actually made the case for the need for a right to independent advocacy, if required, and for that to be in the bill. And I think people like Pam Duncan made an extremely good case in that regard. And I do think in general there is a very good case for this. And at the moment I'd be inclined to support the amendment. I will await the Minister's comments with interest.
Simpson.
I too will await the Minister's comments, because I think independent advocacy is a critical part of the whole structure. And I think in answer to Gil Patterson's point, the procurement system the local authority should use would be on the basis of individual cases and not on the basis of a generalised setting up of an independent advocacy service. And that is perfectly possible. So it would only be, as Drew Smith has said, those who actually wish to avail themselves of this that would actually involve a cost to the local authority. But it is imperative that no one should be prevented from undertaking what is proposed in this bill, and which the government are very keen on, because of the fact that they haven't actually got independent advocacy in order to ensure that both their assessment and the outturn of the package that they're offered is one which they feel is appropriate for them.
Okay, Minister.
Thank you, Convener. I'm very clear that independent advocacy services have a vital role to play in delivering this bill, and that independent advocacy plays a vital role in helping those who need support to express their views. However, I'm not convinced that a general right to advocacy should be provided in this bill. As I said at stage one, people should have access to a range of support services, but not everyone will want or require an independent advocate in every instance. This was a view that was shared by this committee in their Stage 1 report. It would be inappropriate for this legislation to privilege one type of support when many others will choose to access support from other sources, such as carers organisations and user-led support organisations. It is worth highlighting that a large group of people will have a right to advocacy as part of their social care assessment under the Mental Health Care and Treatment Scotland Act 2003. The 2003 Act provides a right to advocacy for every person, both adult and child, with a mental disorder, as defined under Section 238 of the Act, which includes people with learning disabilities and mental ill health. It should reassure the committee to know that the statutory and best practice guidance which will accompany this bill will advise social work professionals to consider whether advocacy is required each time they have a discussion with or assess an individual. However, I'd be happy to have further discussions with Drew Smith on this matter prior to stage 3. However, I would ask that Drew Smith withdraw Amendment 32, and if it is pressed to the vote, I would ask that the committee reject it.
Drew Smith to wind up. Press a withdrawal.
Thank you, Convener. I spoke at some length in moving the amendment, so I'll hopefully just be a bit quicker. But just to respond, I think, to the point that Mark MacDonald and Gil Patterson were making, and I think it is quite clear that securing what we're doing here is providing an opportunity and not providing a system where everyone would have to have a system of advocacy, or that advocacy service that an advocate would have to be appointed in order for someone to demonstrate that they didn't need an advocate. I don't think that would be a sensible way to proceed, but I don't think that's what the amendment says. grateful for others' comments. I mean, we did have quite a significant evidence about this at stage one. There has been considerable debate about it, and I think we are all actually clear, Minister, that not everyone requires advocacy. But I do think that advocacy is a different issue from some of the other kinds of support that you mentioned. This bill, to my mind, is all about choice, and certainly at stage one, I said that in order for people's for us to achieve our intentions in this bill, those choices that people are making have to be meaningful. And for that to be the case, then people's voices need to be heard. I think that is a separate issue from the other support that individuals might seek, to say that their voices must be heard, and that is the crucial role of an independent advocate, and that is what, by not including a right to independent advocacy, we run the risk of creating a situation where if one person in any local authority in Scotland who requires an independent advocacy in order to make their choice meaningful, in order to exercise the choice that Parliament is seeking to give to them, they are not able to do so because we have failed to provide that right. However, in light of the Minister's comments that he is willing to have some further discussion about this before stage 3, I'm happy not to move at this point, Convener.
Do you have the committee's agreement to withdraw the amendment? Thank you. The question is then that sections 9 and 10 be agreed to. Are we all agreed? Thank you. Call Amendment 33 in the name of Alison McInnes and a group on its own. Alison McInnes to move and speak to the amendment.
Thank you, Convener. Well, I hope this amendment is self-explanatory. It's not made clear in the bill that opting for self-directed support is a reversible choice. And for it to be a proper choice, of course, people must be able to say, I've tried this, but it's not working for me. So it shouldn't only be about a change of circumstances, but about what is best for the person again. And I am concerned that as it stands, material change in this clause could be interpreted very narrowly. This amendment would provide greater clarity on that matter.
Other members? Gil Patterson.
One of the aspects, I think, for the need for this bill is that assessments in some parts of the system have not been good. But of course, implicit in what the government's doing and this bill's doing is assessments will be on a regular basis. And so therefore that in itself should be picked up. But the idea that you have this bill in some way fixes a person's position is patently wrong, that they have this choice in a rolling programme. So therefore, you know, I couldn't support it. I understand, I actually agree with exactly what you're talking about, but I think implicit in what we're trying to do here is make choices readily available, and that councils do engage and do continually look at what's happening to individuals and monitor it and make changes if required, based on what that individual thinks is good for themselves.
Richard Simpson.
It does seem to me that if I interpret the section 11 subsection 2 correctly, the authority must offer the person another opportunity to choose one of the options, and that this section is about further choice or material change of circumstances. So I'm just not sure quite how Alison McInnes's amendment actually adds further layers in an appropriate way, but I'd be interested to hear what the Minister has to say before coming to a conclusion on this.
Any other members? Minister.
Thank you, Convener. I'll speak to Alison McInnes's Amendment 33. The bill already provides a significant opportunity for a person to change options if necessary. Section 11 requires local authorities to offer individuals the opportunity to change their choice of options. It does so when the local authority becomes aware of a material change in circumstances. Where a person decides that the selected option is not appropriate to their circumstances, they will have to make the local authority aware of this change. In this situation, the bill already provides for the opportunity for change. Section 11.3 provides that the authority and the person may agree that the opportunity to choose another option can be taken up even if there has not been a material change in circumstances. I do not believe it appropriate to oblige the authority to offer another choice for a reason solely determined by the supported person. The correct balance where there is not a material change of circumstances is that the authority and the supported person agree to a review. Nevertheless, we need to be clear that a person's support, where a person's support is not meeting the agreed outcomes in their support plan, the support needs to be reviewed and other options considered. The statutory guidance that will accompany the bill will also make this clear. I therefore invite Alison McInnes to withdraw Amendment 33.
Alison McInnes to wind up. Press a withdrawal.
Thank you. I appreciate the comments from Gil Patterson. And I suppose you say it's all implicit in the bill. It is indeed. And what I'm trying to do is make it absolutely explicit. The Minister has mentioned material change as the trigger for it being able to reconsider the case. And what I'm trying to define is that one of those material changes would be that the individual says, it just does not work for me, this. I thought it was going to work, this option, but it's not working. Now, you might well get local authorities to say, well, there's not really a change in your circumstances. So I suppose it's a kind of belt and braces approach, and I would press the amendment.
Okay. The question is then that Amendment 33 be agreed to. Are we all agreed? No. Did we have a yes?
No, it's a no.
It's a no. We have to have a division.
Yeah, those in favour of the amendment.
Right, okay. Those in favour of the amendment? No. Those against the amendment? Abstentions? Thank you. The amendment is therefore not agreed to.
I myself to return to the Justice Committee. Would that be appropriate?
Right, fine.
Thank you.
You're spared. The question is that then that Section 11 be agreed to. Are we all agreed? Yes. Call Amendments 13 in the name of the Minister, group with Amendments 17, 18 and 19. Minister to move Amendment 13 and speak to all amendments in the group.
Thank you, Convener. I'll speak to Amendments 13 and 17 to 19. The amendments arise from discussions with and consideration of the recommendations made by the Subordinate Legislation Committee. Before moving to explain the purpose and effect of the amendments, I would like to again express my thanks to that committee for the role it's played in scrutinising the subordinate legislation powers within the bill. Amendment 17 will make consultation a formal precondition before a draft of regulations to be made under Section 12 or Section 21 can be laid before Parliament. This requirement would be in addition to the affirmative procedure already applicable in such regulations in terms of the bill. I hasten to add that the Scottish Government would have every intention of consulting before modifying any of the options or disapplying the local authority duty. However, I agree with the Subordinate Legislation Committee that it is expedient to make this a statutory obligation in this case. Amendment 13 applies to the power to modify options in Section 12. It adds sections 13(2)(b) and 21(1)(a) to the list of provisions which may be amended by virtue of Section 12. This is a necessary technical amendment, as both of these provisions may require consequential amendment if the power in Section 12 is used. Lastly, I turn to Amendment 18 and 19. This relates to Section 21 of the Bill, which provides a power to disapply the duty to offer self-directed options in specific circumstances. The purpose behind this power is primarily associated with Option 1 and 2 in the Bill, where there are likely to be specific circumstances where choice over provision would simply not be appropriate. The intention is to remove choice in these circumstances, not to remove support. Amendment 18 and 19 therefore clarify that if Section 21 power is used, the regulation must, rather than may, include provision to deem a person to have chosen option 3. I move Amendment 13 and ask the committee to support the other amendments in my name.
Thank you. Any members wish to participate? Richard Simpson.
I think it is critical that if the ministers are going to have power by regulation to modify primary legislation, which it appears to me is the case under 12 subsection A, where modification of section 3 may occur simply on the wish of the minister, then it is absolutely vital that we do have extensive consultation. I have to say I remain nervous about this section of the bill because I do not believe that primary legislation should be capable of amendment in this way. I think that the options 1, 2, 3 and 4 do cover the bases in terms of self-directed care, and I can't conceive of a situation in which options 1, 2, 3 and 4 might need to be modified. However, I'm comfortable to support the government's amendments at this point in time, but will want to take further advice before stage 3 to determine whether this section, as it is currently written, is actually appropriate.
Any other members? No. The question is then... the Minister's to wind up. I'm sure he's not got much more to add to that, I'm sure.
Well, the amendments were brought forward reflect the recommendations that were made by the Subordinate Legislation Committee to ensure that there is full public consultation prior to any changes. The reason that there may be a requirement for changes in the future is to adapt to future innovation within social work practice that may occur. Social care provision over the last 15-20 years has changed dramatically, and therefore it's appropriate to have provision within the bill that can allow it to be modified with the appropriate checks and balances around that so that it can reflect innovation that does take place.
Question is then that Amendment 13 be agreed to. Are we all agreed? Thank you. The question is then that Section 12 be agreed to. Are we all agreed? Thank you. Call Amendment 34 in the name of Jackie Bailey, grouped with Amendments 43 and 17A. Jackie Bailey to move Amendment 34 and speak to all amendments in the group.
Thank you very much, Convener. And I was going to wish you a good morning, but we seem to have slipped into the afternoon. I want to speak to Amendments 34, 43 and 17A in my name. And I gather Amendment 34 has excited a degree of interest, and rightly so. Indeed, the committee itself spent some time considering this issue, which of course is whether it would be appropriate to register or regulate personal assistance. Now, let me say at the outset, because I think it's important to do so, that I absolutely accept the view of the very many disabled organisations and disabled people that they don't want regulation. They would prefer not to be viewed as vulnerable and would prefer not to be viewed as in some way needing protection. And I understand all of that. Rather, they would prefer for people themselves to be given the tools to make the right choices. And again, I agree with that. I also recognise that for the disabled person, they want the right to employ personal assistance because they feel that that's a way of them remaining in control of much more flexible support, and I accept that. And I accept also that there is a view that the focus should be on training of the disabled person to become a good employer and to recruit safely rather than relying on legislation. Now, in recognising and supporting those views, it is also our job as a Parliament to weigh up the potential risks that may occur. I've received some correspondence from parents that actually caused me to stop and reflect a little more on this question, and that's what I'm asking the committee and the Minister to do. These parents were worried by about the safety of their child. He was a vulnerable adult, he lives independently of them, he has complex needs. They naturally didn't want him under any circumstances to be taken advantage of in any way, and I think that's something we would all agree with. But they felt that the reassurance of having some registration, some regulation would be important not just for their peace of mind, but also for their son's well-being. It's also the case, and we need to recognise this, that there have been instances of abuse, not confined to residential homes, that have shocked us, where people have absolutely abused their positions of trust. So the question for us all is how we guard against that. I don't believe and I have to say this, that simply the process of registering or regulating personal assistance will be some sort of panacea. I don't think that's the case. But it does require us to provide much more serious thought about how we achieve a balance between those disabled people who rightly want their independence and to decide how to employ their personal assistance with the needs of more vulnerable people. And it is incumbent on us to strike the balance between the two. I'm also struck that when this committee asked those responsible for regulation and registration, when they actually appeared before the committee, there was a divided view about how best to proceed. And I think that does underline the genuine quandary facing both the committee and the government. The Coalition of Care and Support Providers argued for a basic level of accreditation and then subject to PVG checks. The Scottish Social Services Council themselves argued for registration, for minimum induction training, and to distinguish between complex care and care for particularly vulnerable service users, so that that category could be regulated, but you didn't limit personal choice for everybody else unfairly. Now, I recognise the Minister and the committee don't want over-professionalisation of personal assistance. I share that view. But the committee itself considered that more could be done to reduce the risk and thought there was merit in the recommendations from the Scottish Services Council. So for that reason, the amendment does not put this on the face of the bill or suggest that it needs to be done now. Put quite simply, the amendment gives a power to ministers to bring forward regulations at some point in the future. That doesn't mean that they have to, but they could do so in the future if they considered it to be necessary. And on balance, I think it's effectively a safety net for the future. Amendment 43, Convener, is related to Amendment 34, and this seeks the procedure to be done by affirmative resolution rather than negative resolution. And I think that reflects the importance of the issue and the need to engage in more discussion and scrutiny should any such regulations come before the Parliament. I recognise that the Subordinate Legislation Committee believed that Section 13, which sets out secondary legislation, was appropriate in the use of the negative procedure. But of course, by adding this, we're adding something quite substantial, which is why I've gone for affirmative procedure. Amendment 17A is, of course, a technical amendment which reflects the Minister's own consideration of the Subordinate Legislation Committee recommendations. So can I move Amendment 34 in my name?
Other members? Drew Smith.
Thank you, Convener. Just briefly, I would associate myself with what Jackie Bailey said in relation to the desire of many people affected by the self-directed support bill for independent living and the sensitivities that this amendment raises. However, I think she probably is right to highlight the fact that what the effect of this would be is to provide ministers with the power and the option to think about registration and regulation in the future should it be deemed necessary, rather than to think that at this stage, at stage 2 of the SDS bill, we have resolved this, because I don't think it was resolved in the evidence that we heard, but I think there remain some quite significant questions. The only other thing that I would add in is that in relation to people employed as personal assistants, I would hope that should a future scheme of registration or regulation or whatever it might be in the future would also be of support to those personal assistants, because by thinking about through some of the issues of registration, we often open the door to training, to other opportunities. And while I agree we don't want to professionalise the workforce, I think there is, in any labour situation, there is a responsibility on us to consider both sides and to ensure that people are properly supported, whether or not they are the procurer of the service or the provider of it.
Any other members? I see Bob, Nanette. Okay. Nanette and Bob.
I think there is quite a fine line, as Jackie Bailey said, between sort of regulation for people who really don't want to have a fully qualified, registered assistant. But again, as she said, I think as a Parliament, we do have to protect the vulnerable people and prevent them from where we can, as far as possible, from being abused in a very vulnerable situation. So I think I would go along with Jackie Bailey's amendment, particularly the fact that she's putting it into regulation, and also that if there would have to be an affirmative procedure. I think I'd go very much along with that.
Bob Doris.
Convener, just very briefly, the committee was finally balanced in how to take this forward, and I don't think I'm there yet with saying this power should be extended in terms of the bill. A slight nervousness from my part that a power may become an expectation from certain groups to use it when we're not as yet clear about how we would take it forward. Also, we've used the expression a number of times about professionalising the at-home workforce and personal assistants. Some of them are deeply professional in caring individuals, and I think we should be quite careful in how we use that word professionalisation. I just wanted to put that on the record as well, but also to associate myself with the comments made about how we support that care staff. Now, that doesn't have to be through regulation, I don't think, but also to put on record that I'd be looking at how we can take forward greater support for people in that situation.
Any other members? Gail Patterson.
I've got haven't been covered. I mean, I'm anxious about this matter itself, because on one hand we're trying to make it more readily available for family members. So you know, there's a whole lot of things go through my mind in that regard, and I've already expressed some words in that manner. But vulnerable people come in so many guises, and I don't want to be playing to the television or anything, but the case we're looking with Jimmy Savile, who would ever imagine, you know, young children, 14 years of age, in front of our eyes on the television, these things happening. So, but I don't think you can regulate for these things. It's heavily involved in these issues. I am. You really can't put in something in place that, you know, accommodates all these issues. But you know, the other worry that I've got is people are already in place who are providing this service, and they're unregulated and doing a good job. So to, you know, in some way, you know, my worry is you can in some way stigmatise by saying that, you know, that we should regulate for everyone. You know, I'm kind of caught between two stools here. One is to defend, to protect people that are vulnerable, and the other is to, you know, ordinary family members who are doing the job at the present time and doing it very well, and probably in a very professional way. But, you know, if you put something in that clearly professionalises this part of what we're trying to provide, would worry me. It's a long way. I would like to hear what the Minister's got to say.
No other members. Minister.
Thank you, Convener. Amendment 34 would introduce a regulation-making power that ministers would be able to use to establish a scheme that would regulate the quality of support provided by personal assistants employed through a direct payment. One of the key strengths of the self-directed support mechanism is the flexibility that it affords to individuals, and it's a key factor in that flexibility about how the workforce respond to it. It is also worth keeping in mind that it's not compulsory that anyone has to choose a direct payment. There are three other options that they could choose to use should they wish to do so. At stage one, witnesses from groups representing disabled people, such as Independent Living in Scotland and the Scottish Personal Employers Network, explained in personal terms the vital importance of being able to choose their own employees and of taking responsibility for their training. The committee will recall Pam Duncan from Independent Living in Scotland, who explained that what was important to her was not that her PA had been on a food hygiene course, but that they knew how to blow dry and straighten her hair. I'm not convinced of the need for a regulation-making power that would, if used, limit flexibility, especially when there are already proportionate safeguards in place to protect people who do employ or receive support from a personal assistant. The PVG scheme strikes a balance between proportionate protection and also robust regulation. A personal employer who chooses to employ a PA who is a member of the PVG scheme is entitled to see that person's scheme membership statement to confirm that they are not barred from doing regulated work with adults or children. Social workers have significant adult protection duties, including a responsibility to ensure the personal employer understands the importance of the PVG scheme membership, the rules on seeking and sharing information, and the risks of employing an unsuitable individual. Social workers also have a critical role in making sure that employers of a PA will fulfil their responsibilities in training of their PAs and the skills necessary to meet the needs of the supported person. In complying with their duty of care, social workers must use their professional judgment when signing off a direct payment package involving a PA. If they do not think that the PA can provide the services that are necessary to meet the assessed needs of the supported person in a safe way, then they must not agree to that support package. As I mentioned in my response to the Health and Sport Committee Stage 1 report, Scottish Government officials are working closely with their partners, including SSSC, to improve the training and awareness of PAs through the SDS Workforce Action Plan. The Scottish Personal Assistant Employer Network and a number of other local organisations are already supporting employers with recruitment and training areas. The Scottish Government is supporting Self-Directed Support Scotland in partnership with the Association of Directors of Social Work to map the range and variation in information and support provided on self-directed support right across Scotland. This information from this exercise will inform further activity to ensure comprehensive national advice on PA employment, including information about SSSC codes of practice. In striking a balance, the need for proportionate safeguards with the right of individuals to make decisions, I do not think it necessary or desirable to include a regulation-making power in this bill, which is intended to be used to establish a scheme for the registration of PAs. Amendment 43 and 17A will make all regulations under Section 13 subject to affirmative procedure and a statutory duty to consult. There is perhaps some merit in applying these requirements to regulations establishing a regulation scheme. However, I have said that I do not support Amendment 34. And even if Amendment 34 was successful, I think Amendment 43 and 17A go too far in applying to the whole of Section 13, even where it is used to make other regulations about direct payments. The Subordinate Legislation Committee was satisfied that the procedures and consultation powers with the consultation powers for the existing provisions in the bill. I therefore do not support the amendments in this group, and I would invite Jackie Bailey to withdraw Amendment 34 and not to move Amendments 43 and 7A.
Jackie Bailey, to wind up, press or withdraw?
I intend to press the amendments, Convener, and I do so and address the points that have been made. Can I say specifically to Bob Doris that government legislation, indeed, of this government and previous governments, is littered with powers that haven't yet been enacted, so I don't think it would be creating an inappropriate expectation. I think this is more about safeguarding those who are most vulnerable. Can I also suggest that to the Minister that I recognise and absolutely support the need for flexibility. What we're not trying to do is have a scheme that covers absolutely everybody, but actually is one that is proportionate. Now, the Minister in his comments appeared to almost be suggesting that social workers themselves would assume a lot of these responsibilities. I don't think that's reasonable, given their other duties, and in practical terms is unlikely to be consistently applied. In terms of subordinate legislation, I absolutely agree that Section 13 is entirely appropriate for the current provisions in the bill. what I would be adding, if Amendment 34 was successful, is quite a substantive new power for the Minister to bring forward regulations. And I think in those circumstances, even he would agree that the affirmative procedure would be suitable. Convener, this is all about arriving at a balance, and I think what I've tried to do is at least provide a proportionate response to some of the risks that are likely to come up. It is absolutely legitimate, the view of disabled people, that they should be able to make their own choices about personal assistance, but equally it is our responsibility to safeguard those who may be particularly vulnerable. And I rest on the fact, Convener, that the advice to this committee was from the Scottish Social Services Council, the government's own agency, and I would urge you to listen very carefully to them. Thank you, Convener.
The question is then that Amendment 34 be agreed to. Are we all agreed? No, we have a division. Have a show of hands in support of the amendment, please. 1, 2, 3, 4. All those against? 1, 2, 3, 4, 5. The amendment is not supported. The question is that Section 13 be agreed. Are we all agreed? Thank you. Question is that Section 14 be agreed. Are we all agreed? Call Amendment 35 in the name of Richard Simpson, already debated, with Amendment 23. Richard Simpson to move or not move?
Not moved.
Not move. Do we have the committee's agreement that's not moved? We don't need that. Okay. The question is that Amendment 35 be agreed.
No, it's not been moved, so you just skip on to the next one.
Oh dear. Call Amendment 14 in the name of the Minister, already debated, with Amendment 23. Minister to move formally.
Moved.
Thank you. Question is that Amendment 14 be agreed to. Are we all agreed? Call Amendment 36 in the name of Richard Simpson, already debated, with Amendment 23. Richard Simpson, move or not move?
Not move.
Call Amendment 37 in the name of Richard Simpson, already debated, with Amendment 25. Richard Simpson, move or not move?
Not moved.
Thank you. Call Amendment 15 in the name of the Minister, already debated, with Amendment 23. Minister to formally move.
Moved.
Thank you. Question is that Amendment 15 be agreed to. Are we all agreed? Thank you. Call Amendment 38 in the name of Richard Simpson, already debated, with Amendment 25. Richard Simpson, move or not move?
Not move.
Not move. Call Amendment 16 in the name of the Minister, already debated, with Amendment 23. Minister to move formally.
Moved.
Thank you. Question is then that Amendment 16 be agreed to. Are we all agreed? Thanks. Call Amendment 39 in the name of Richard Simpson, already agreed, with Amendment 23. Richard Simpson to move or not move?
Not move.
Move. Thank you. The question then is that Section 15 be agreed to. Are we all agreed? Thank you. I'm just conscious of the time. Wait, well, I'm going to press on.
You better press on.
Well, I think Bob thinks that we should press
Well,
on.
Convener, I was thinking when previously at the start of the meeting we thought maybe 1 o'clock would be a good time to draw a line under it. It's whether we can dispose of the next section within that time or not.
Well, I'm looking around, and I don't want to constrain the debate in any way, but committee members have been here for 4 hours, and heavy evidence from the Cabinet Secretary on this process. We've got time for next week as well. But if you want to press on, I can't guarantee you're finishing it at 1.
I think we should hold off to next week. Yeah, if we can't, I think we should hold off to next week in that case, Convener, because of other. Yeah.
I may have helpful comments for the two members for moving the next set of amendments, which should help to move things on, if it would be useful.
We're tempted. I'm just, it's just important for the committee to know that I can't guarantee for 1 o'clock to be here, some of us for about 5 hours by that point. We're pressing on.
Yes, let's press on.
Okay.
Tantalised by the prospect.
Can I call Amendment 40 in the name of Jackie Bailey and a group of its own? Jackie Bailey to move and speak to the amendment. Other members. Oh. will be called in due course. Jackie Bailey.
Thank you very much, Convener. Having packed up my stuff, I rapidly unpack in anticipation that the Minister is going to do something interesting. I'm very pleased, Convener, to move Amendment 40 in my name and hope that the Committee and indeed the Minister might be minded to accept this. The bill introduces at Section 16 the prospect of charging carers for services they receive. And in moving this amendment, I think we should all have regard to the unanimous view expressed to MSPs. And let me quote from the paper from all of the carers umbrella groups, I believe, in Scotland, when they say the proposed bill will give local authorities the power to charge carers for the services they are assessed as needing. We strongly oppose this. As key partners in care and the largest contributors of care, it is unjust to charge carers for the cost of services which help them to carry out that caring role. It might be helpful for members to recall the Community Care and Health Scotland Act of 2002, which I'm sure the Minister was involved with, which established the principle that carers are in fact care providers and therefore require resources to enable them to do their caring role in very much the same way as health and social care workers do. That might be training. In other instances, it might be respite. Usually, it is an incredibly small amount of money to give the carers the tools to do the job, or indeed some light relief so that they can be sustained in carrying on caring. There is a distinction, therefore, I believe, between the support provided to carers and those cared for. Charging carers is viewed as very much contradictory to the principle we enshrined in the legislation in 2002, but it's also contradictory to the approach taken by this Parliament. Whether it's the committee's Stage 1 report that recognised the vital contribution of carers, whether it's the Scottish Government that regularly cites how much carers saved the state by making the contribution that they do, it is clear that we value them, but we need to do more than simply say that. If we support carers, we help them to continue caring. It benefits all of us, it benefits the person cared for, and it will help prevent crisis and enable people to carry on with what they're doing. And on that point, in anticipation of the Minister's comments, Convener, I will move the amendment in my name.
Thank you. Minister. Other members? If there are any other members wishing to speak, don't want to preempt it. Right, Minister, thank you.
Thank you, Convener. I note Amendment 40 and the arguments which have been put forward by Jackie Bailey. Section 16 was included in the bill as largely technical provision to provide consistency in legislative powers on charging. Some argue that carers are providers in their own right and therefore charges should never be applied to any support that they might receive. I can recognise that there is merit in this view. However, charging, as I'm sure Jackie Bailey is aware, is a complex area and one where we need to be careful of unintended consequences of the amendment that she has proposed. We have to give detailed thought to the interaction between services being provided to the cared for person and services provided to the carer themselves. However, I'd be happy to meet with Jackie Bailey in the time permitted prior to Stage 3 in order that we can discuss the possible consequences which I've outlined and whether we can consider whether there are further steps that could be taken in this area. In conclusion, I would ask Jackie Bailey to withdraw Amendment 40 but to meet with us prior to Stage 3 to discuss this issue further.
Jackie Bailey to respond.
Convener, whilst I don't accept that there are unintended consequences to this amendment, in the spirit of cooperation, I'm happy to withdraw and look forward to my discussions with the Minister.
It's worth waiting for. I hope the committee agree that you're now withdrawing your amendment.
Agreed. Yes.
Thank you. Call Amendment 41 in the name of Nanette Millen. Nanette to move and speak to the amendment.
Thank you, Convener. I would say...
Amendment 16.
We should have questioned them. Section 16. Question is that Section 16 be agreed.
Right, okay. I've omitted to put the question that section, do the committee agreement that Section 16 be agreed to?
Agreed, yes.
We now go back to Nanette to move and speak to the amendment.
Can I say at the outset, Convener, thank you, that Amendment 41 is a probing amendment based on representations by the many organisations which make up the Health and Social Care Alliance Scotland, who feel that it's important that information on accessing self-directed support is offered to people who may be entitled to it at the very earliest opportunity so that they can make informed decisions about their future support needs, and that for hospital inpatients this should be at the time they're discharged home from secondary healthcare services. If local authorities communicate with health services in their area at this time to identify people who may require information about SDS after a spell in hospital, it's felt by the Alliance that this would lay the groundwork for effective collaboration between health and social services in seeking positive health and social care outcomes for long-term conditions and for people with disabilities. Such cooperation will clearly be essential if the integration of health and social care is to be effective, and I'd be interested to hear the Minister's views on this amendment vis-à-vis the forthcoming legislation on the integration of health and social care before deciding whether or not to press my amendment.
Thank you. Any other members?
I think I may briefly, Convener, just say that my one concern here is that instigating a broad discussion is appropriate, but since most services are now moving towards having an acute rehabilitative phase before an assessment of the long-term needs is made, I'm not just sure that this is phrased in quite the way that I would want to see it.
Any other members? Minister?
Thank you, Convener. The promotion of availability of self-directed support under Section 17 is broad and aims to ensure local authorities actively publicise information so that both people who may need support and people working in local authorities are aware of the relevance of self-directed support to eligible people. Amendment 41 proposes that local authorities must take reasonable steps to promote the availability of self-directed support options to, amongst others, people being discharged from hospital. I agree that when a person discharged from hospital is eligible for support under the 1968 Act, they should have the opportunity to choose one of the self-directed support options. The bill already provides for this. Eligible people, including those discharged from hospital, must be given the options available under the bill. As I've stated in relation to some other amendments, the statutory guidance will make this clear. I do not think that this amendment would widen the provision currently in the bill, and I do not think it's helpful to dilute the generality of Section 17 by picking out one type of group in need of support. If the amendment is pressed to vote, I would therefore ask that the committee reject it.
Thank you. Nanette Millen to wind up. Press a withdrawal.
I think, having heard the Minister, I think I would press ahead with moving my amendment.
The question is then that Amendment 41 be agreed to. Are we all agreed? No. We move to a vote. Can I have a show of hands in support of the amendment? One. Those against? The amendment is not agreed to. Call Amendment 42 in the name of Nanette Millen and the group on its own, Nanette Millen, to move and speak to the amendment.
Thank you, Convener. Again, this amendment is supported by the Alliance and also by the Coalition of Care Support Providers in Scotland. For individuals to have a real choice of social care services, there needs to be available a range of high-quality, personalised support services to choose from. And there's a sense that if nothing is done positively to promote and sustain the availability of a range of providers, then it's likely that in time there will remain only a small number of providers, and these are likely to be the larger organisations with sufficient economies of scale to survive. Effectively, this would result in no real choice for service users, and the amendment seeks to put a duty on local authorities to take reasonable steps from time to time to try and ensure the continuing availability of a suitable range of providers, which would help to realise the ambitions of the bill by giving greater choice and control to users within a diverse marketplace of service providers.
Any other members? Richard Simpson.
I have some slight concern. I have some considerable sympathy with what Nanette Millen is proposing in this amendment. It is clearly not practical if there is no choice for the options to actually be real. So I have some sympathy, as I say, for this amendment. The only bit of it that I have some concerns with is placing the local authority in a position of having to sustain these services. Again, I think that's just going a step too far. And I think that, therefore, We'll be interested to hear what the Minister has to say, but at the moment I'm minded to probably abstain on this motion at this time and look at it again before stage 3.
Any other members? Minister?
Convener, Amendment 42 places a duty on local authorities to consider whether any steps could be reasonably be taken to promote and sustain a diverse market for social care. I appreciate the vital importance of ensuring that people have a range of services to choose from. This bill is about meeting people's expectations about having choice and control over social care support they receive. Clearly, that choice and control is undermined if a person can only choose between a few providers in their area. For the bill to have a meaningful impact, people must have choice within the market of service providers. However, I do not support the amendment proposed by Nanette Millen in its currently drafted form. I have concerns around local authorities taking steps to sustain a diverse market. I think we would have to give full consideration to the possible consequences of that, in particular how it would interact with existing procurement legislation. However, I can support the principle behind the remainder of Nanette Millen's amendment. The way local authorities procure and commission services affect everyone who receives social care services. Local commissioning strategies should be outcome-focused and long-term, setting out how current provision needs to change to meet future needs. The statutory guidance that will follow this bill will address the question of the role of local authorities in commissioning services in detail and will help to ensure that the need to offer choice to people within the marketplace is embedded within local commissioning strategies. In light of this, I would be happy to work with Nanette Millen with a view to drafting a workable amendment for stage 3 that will encourage local authorities to facilitate diversity, and therefore I would invite Nanette Millen to withdraw Amendment 42.
The Minister said I am happy to withdraw the amendment at this stage because clearly he accepts the principle.
Thank you. Do we have the committee's agreement? Yes. Thank you. The question is then that section 17 be agreed to. Are we all agreed? The question is that sections 18 and 19 be agreed. Are we all agreed? Call Amendment 43 in the name of Jackie Bailey, already debated with Amendment 34. Jackie Bailey, to move or not move?
Not move, Convener.
Call Amendment 17 in the name of the Minister, already debated with Amendment 13. Minister, to move formally?
Moved.
Thank you. Call Amendment 17A in the name of Jackie Bailey, already debated with Amendment 34. Jackie Bailey, to move or not move?
Not move, Convener.
Thank you. The question is that Amendment 17 be agreed to. Are we all agreed? Thank you. The question is that Section 20 be agreed to. Are we all agreed? Call Amendment 18 in the name of the Minister, already debated with Amendment 13. Minister, to move formally.
Moved.
Thank you. The question is that Amendment 18 be agreed to. Are we all agreed? Call Amendment 19 in the name of the Minister, already debated with Amendment 13. Minister, to move formally.
Moved.
Thank you. The question is that Amendment 19 be agreed to. Are we all agreed? The question is that Section 21 be agreed to. Are we all agreed? Call Amendment 20 in the name of the Minister, already debated with Amendment 2. Minister, to move formally.
Moved.
The question is that Amendment 20 be agreed to. Are we all agreed? The question is that Section 22 be agreed to. Are we all agreed? Thank you. Question is that Sections 23 to 27 be agreed to. Are we all agreed? The question is that the long title be agreed to. Are we all agreed? Thank you. That ends Stage 2 consideration. I thank you for your participation, patience. It made that good progress this morning. Members should note that the bill will be reprinted as amended and will be available from tomorrow morning. Parliament has not yet determined when Stage 3 will take place, but members can now lodge Stage 3 amendments at any time with the legislation team. Members will, in due course, be informed of the deadlines of lodging amendments once it has been determined. I thank the Minister and his team and all of those who participated here this morning. Thank you very much.